You know, you want to practice the singing to yourself. Put earbuds in your phone. You learn how much faster you got to do them. Once you start out, so those weren't 60 when you were faster.
Can you kill that light above this?
I think it's right over there. They give you guys enough light? Yep. Looks good. Oh, yeah. 180. The big picture. Crunch. Yeah. Yeah, I'm saying what you're doing, and not on the first step one, you know it. No, sorry, you feel it. You're going to feel tall, you get up. You feel it. That matter when you're not going to look there. So when you take lazy, you hit all over. Remember that you're going to run through. There he is. The hell is taking this long? Mechanical problems with my truck. Those great fixes. I'm gonna have to take it up there and get it fixed down there. I changed the battery yesterday. Thank you, fuel filter. No, anytime you work on something that's on fire, like like a lawnmower has to be better. I gotta have them replace that battery post, the red one. Because that corrosion is eating through it, and it's especially made one that only dealership has. So I guess I didn't have a cotton good enough, and I guess the paint it came off on the light, and you go down. Now, because we took the battery, changed the lock, and alternated, they kept running the truck. But the battery said, you just wiggle it up and just pop off. Hope that's all it's doing. No, I just have to take the whole thing up, I guess. Get both those in first on, take out the back country roads. Or just let that fix it. I just think he was loaded with that thing for about 16 hours the day before and yesterday. So I think it was something I did, it's probably caught fire the day before. Yeah. Well, is that written on his up there, or what is it? No, that's not cautious. So it's all there. When you went by there, more was on fire, that's more the front or the just the easy part on fire. Grab the pipe from the out of the top a little bit. So that's on this one. When I worked on a bunch of, there's a bunch of those like that much grass and old stuff all around the motor. And I had to take the whole front of it off, and I was keeping it all off there. And a bunch of it fell on the exhaust, and I threw the exhaust off. I think you can never fell down under the exhaust, you just sit underneath it. And the air space is just so hot out like that. Remember I pulled up the whole, some things what happened to that grass top fire. bars. There was plenty of wall frame already.
Look at the meat
I didn't
cream.
know that one was gonna be.
Look at the
The
meat cream.
gas line comes up, but the gas line goes to.
Yeah, look, and Travis was passing by and seen her and checked her out.
Travis, and then Holford.
You passed her by, didn't you?
Oh, downtown. Oh, okay. No, I thought you were talking, we were talking about up there at Rome.
No.
I mean, his wife was broke down downtown.
Right. Out by Benny. You wanna go?
He thought it was you in that truck. I can't know him.
Yeah. It was too. But it was my wife.
Something like that. You wish I could get back.
But Travis was passing by, I guess, stopped and brought her home, and we went back out there and fixed the truck.
I've never seen it. I've seen it, was right here. You were down on that road.
It's fixed, okay now. Maybe.
So tomorrow,
Well, I'm thinking about having my brother get in one in Texas. We,
Well,
put those breaking yards down there in Texas. That's a nice college, dude. A real nice college.
So we got them,
Three of the best part I got was just in breaking yards. Nothing wrong with them, nothing. And of course, I crashed one of them with this lady. But I took her to the fall.
I'll say that.
But she was sick. You know how to yell, and you yell and you go. Well, this one just stopped dead in the middle. And her eye.
That'd be your fault.
I told her that car. It was my brother's insurance. Then the other one, I don't know what happened to it.
all right, I guess if Leedy wants to jump on, they'll shoot me a message or something because I don't see anybody getting on, and I've had a couple messages from a couple other people that said that they're busy or whatever. So we'll get started without them. Telling you, it's not beneficial. Let me get the water. So we're going to go over Chapter 8, cardiac arrest. Many of you have already had a CPR class. Those that haven't, we will go ahead and we'll do a CPR class more towards the lab. But we'll go ahead and just go over Chapter 8 and kind of quick. Kind of the plan for this week, I think we will finish sections 1 and 2. Or 1 and 2, right? All the way through Chapter 8, Section 1 and 2, correct? So let's plan on actually having our test next Monday. So we'll finish Chapter 8 today, and then we could kind of start reviewing to tomorrow night, and maybe hit a chapter or two, the next section on our last class on Wednesday. But I'll definitely open up Wednesday night to answering questions that you guys have. So I know it's going to be really fast to be able to ask some questions in class, but go ahead and try to get chapters 1 through 8 read, and that way we could talk about things that you guys are having issues with. Now, I understand that you guys are all pretty busy. Oh, hey, look, Leedy's there. Hello, Leedy.
I'm pretty sure Jacinda's the only one coming.
Okay, that's fine. However you guys roll. We're just talking about kind of what we're planning on doing this week. We're going to plan on doing our section 1 and 2 large test next Monday. So tonight we're going to finish chapter 8. We will kind of then just kind of go over the end of the chapter questions. Is everybody that has had their book, are they done with the questions that we've gone through so far? You haven't had your book yet, right?
I've done through section 6.
Okay. Through section 6, Lee. Try to, and I know it's going to be a lot of work for those that don't. Chapter 6 is good. I mean, you have two more chapters and you're squared away for questions. But tomorrow night I would like to go over the end of chapter question. Just kind of maybe have somebody read a question and you guys discuss what you think it is. I don't want to read them all myself. I think it's lame. Kind of do it that way. Have you guys talk about it, discuss it. I'll be here to facilitate the conversation. And then definitely on Wednesday, if you guys could be ready for the test so that you can ask questions Wednesday on things that you're having problems with. Now, like I was getting ready to say, I understand that everybody's busy and everybody has jobs. If you don't get done, take Saturday or Sunday night to do it, and you are going, you have questions while you're doing it. Don't hesitate to send me an email with questions. And I'll probably send the question out to everybody. I won't say there's you that send it. I'll just copy the question and send out the question and answer so everybody has it. If you have that question, there's a good chance that somebody else has that question. So I'll do it that way while you guys are studying. Monday, I'll be a little more lenient in this first test. I'm not saying we'll definitely have to talk about what you're going to do to improve your grade, what I can do to help you improve your grade. There's something I can do. I'm in this with you guys. I'm here to help you out as much as I can. That's kind of what we plan on doing, just hitting chapter 8 tonight. Maybe on Wednesday, maybe doing a couple of the chapters, and then but kind of the rest of the week just using to go over the into chapter questions. Starting whenever we start this next or whenever after the test Monday, I really want you guys to have the section that we're going to talk about that night. We'll try to have at least part of it read and ready to discuss. I know that we've kind of been it's kind of been rough to do that because everybody's trying to get their books. This class is really fast. I think we just got to start text. Okay, not from Leedy. But I want us to try to get caught up so that we're the night that we're going to try to discuss it is the night that you guys are ready for it. Got to keep checking there because where it's Leedy. So, all right, so I'm gonna go ahead and open my book to chapter 8 while we're doing this because a lot of what they want me to talk about in the slides is actually a chapter. A little too far. All right. I'm not going to read all the objectives. There's a ton of objectives. So feel free to read those 17 objectives if you want. Objectives for this chapter can be referenced on pages 181 and 182 of your textbook. Like I said, if you feel free, actually it looks like there's 19 different objectives. Holy cow. Leedy, I hope you're not trying to text me because, oh, yes, that is. Okay. Thank you, Jacinda. I got that text. So anyway, we'll go ahead and get started. So topics: the heart, cardiac arrest, chain of survival, pediatric CPR, automated external defibrillators, AEDs, putting it all together, and ethical considerations of cardiac arrest. I'm going to go over the slides, and I'm going to try to go use the book and stuff, but I imagine there's going to be some things I'm going to talk about. I do a lot of the AHA the healthcare provider classes. So I know that they're probably going to leave a few things out of the book that will benefit you guys. So we'll talk about it. So introduction, each day approximately 850 Americans die from sudden cardiac arrest. About every 2 minutes, someone dies of sudden cardiac arrest. EMR plays a critical role. I truly believe not only does the EMR play a critical role, but that a layperson can also play a critical role. The studies show that compressions, if somebody's willing to do compressions on somebody that's gone down, when they first go down, they give that person a better chance of survival if bystander compressions are started right away. Now, obviously, with the adults being in a lethal arrhythmia, a lot of them need to be defibrillated, which we'll talk about AEDs. I think those should be everywhere. Do you guys carry them in your cop car? If there's ever a grant out there, you really should write for it to have it in your cop cars. I know that you guys number a lot more and are able to maneuver a lot better in towns and stuff than ambulances are. And AEDs are awesome. I think they should be everywhere that you have groups of people gather in schools and things like that. So here's the call, dispatch 4:30 p.m. And actually these calls tend to happen at around 6 a.m. whenever some people are waking up. Respond to an office complex for a patient with difficulty breathing. You are 5 minutes away. Dispatch notifies you that CPR is in progress. That's not an uncommon thing to happen right there. So I'll just ask you guys kind of what I said. What are some positive things that you see in that scenario there?
Only 5 minutes away.
It's 5 minutes away, and that dispatch notifies you that CPR is in progress. Guys, that bystander CPR, I think, is going to be a game changer. AHA came out in the middle of their last updates, which they hardly ever do, release a mid-cycle update, but they've released an update that allowed for the heart saver or the layperson to do compression-only CPR, because they found that there's no change in that survival rate between somebody that's just had compressions and somebody that's had compressions and ventilations. The important thing is that the compressions are done and started. So, the heart, guys. This is a picture of heart. I think Jacinda probably could clarify, but I don't think you're going to have to name off all the parts of the heart on your test. Okay, understand that the left side is going to pump oxygenated blood. The left ventricle is going to pump oxygenated blood to the body. The right ventricle is going to pump deoxygenated blood to the lungs. Okay, if you guys can kind of get that basic concept, and remember I told you that this wall here in the heart is thicker because it's going to the body, which is a larger area. That's not really true. They don't exactly know why this part of the heart's thicker, but it's a good way to kind of help you remember that. The left side's thicker, so that's helping pump to the body. Oxygenated blood comes in the left atrium and is pumped down into the left ventricle. It expands out, contracts, and pumps to the body. The right atrium accepts blood from the body, so now it's going to be deoxygenated into the right ventricle, then up into the lung. The better you understand that, I guess the better grasp you're going to have. I really don't think it's going to help you that much on your EMR test. Jacinda might correct me if I'm wrong.
I don't remember having any of that either.
Okay, yeah, I wouldn't think so, Jacinda, but I just want to make sure since you're the most recent person I know that's taking one of these type tests. So all right. So the right atrium receives deoxygenated blood from the body. Right ventricle pumps this blood to the lungs. Basically what I said. Blood travels to the left atria. Blood travels from the left atria to the left ventricle. The left ventricle pumps oxygen-rich blood to the body. Guys, I think if you grasp that, I think that is the lion's share of what you're going to need to comprehend for the EMR class, and possibly even for those that are thinking about doing a basic course. I think, she said it wasn't going to be on the test, but it'll help you understand some of the concepts that may be on the test. So, all right. So, cardiac arrest. Brain begins to die after 4 to 6 minutes. Irreversible damage after 8 to 10 minutes. the causes in adults are different than infant and children. The main cause of adults being cardiac arrest, there's two main lethal arrhythmias that adults go into, and it's because the heart, you have a heart attack or you have an infarct or damage to the heart, and the heart becomes ischemic or lack of oxygen, and it gets irritated, goes into, typically goes into one of two rhythms, ventricular fibrillation or ventricular tachycardia. Okay, so whenever you see, because I know you guys are all Grey's Anatomy fans here, I could tell by the group I'm in. Some of the people at Lee might be, but whenever you see them shock flatline, that is untrue. You don't really shock the flatline. Your AED will not shock flatline. It's going to shock ventricular fibrillation or ventricular tachycardia. And basically, it's just the ventricles, those parts that are pumping to the heart and then pumping to the body. They're just like they described as a bag of worms. They're just that those ventricles are just quivering. Normally, a contraction starts and it almost is like a squeeze or a ringing of the heart. Okay, and those that can't see me, just imagine squeezing a heart from top to bottom. But whenever you have VTAC or VFib, which is the short for ventricular fibrillation, ventricular tachycardia, whenever you have it, those ventricles are no longer contracting; they're just quivering. Okay, and so something's wrong, and so we're going to shock them. That is the most common cause for adults to be in cardiac arrest. Infant and children, their most common cause for cardiac arrest is an airway issue. So whether it's an allergic reaction, an asthma attack, an obstructed airway, that is what causes them to go into cardiac arrest. Okay, so understand your etiologies or the reason that they're in cardiac arrest are different. EMR, patient assessment, cardiac arrest. Signs of cardiac arrest: unresponsive mental status, apnea, cyanosis, pulselessness, and no movement. We know what apnea is? No breathing, correct. Do we know what cyanosis is?
It's
Bluing around the lips. Good job. Well, not just necessarily the lips. Good job on the bluing.
Fingers.
Yeah, cyanosis is bluing of the skin. So obviously we all know what pulselessness is, and then no movement, right? So let's see. I'm just going to see if they go over here. So EMR, patient assessment, cardiac arrest. Checking for a pulse. You're going to check a carotid pulse. Use your index finger and middle finger. Feel for 5 to 10 seconds. Begin chest compressions if unsure whether or not a pulse is present. I'm going to kind of expand on this just a little bit because even though this is part of it, it's not all of it. Notice where he's checking for a pulse. It's in between that sternocleidomastoid muscle we talked about, that big muscle that runs from beyond the ear. It just makes this muscle on the outside, yeah. And then the trachea. That's where you're going to check for the carotid pulse in between those two landmarks. Basically, you'll see a groove on most people. Look around, I'm seeing a groove on a lot of people. So you're gonna slide your fingers over into that groove and feel for a pulse. Okay, I'm gonna go a little bit. I'm gonna go one step further. You're gonna check the patient for responsiveness. Obviously, sir, are you okay? If they don't respond, like the previous picture, we'll go back. Like the previous picture, I'd go ahead and roll this guy over onto, at a minimum on his side, but while I'm checking him onto his back. I'm going to roll him over onto his back. I'm going to, sir, are you okay? No response, roll him onto his back. I'm going to check for a pulse, and at the same time, I'm going to actually get down and I'm going to look for chest rise and listen for any breaths or any respirations, okay? I'm looking for any movement, listen for any breaths, and I'm checking for a pulse. I'm doing this for at least 5 seconds and no more than 10. And if I don't definitely feel a pulse, and I say that for a reason, if I don't see any movement and I don't hear any chest or don't hear any breath, I'm going to go ahead and I'm going to start my compressions. Help pulm on one, get the AD, and now I'm going to start my compressions. The reason I said if you don't definitely feel a pulse is because they have found that even experienced healthcare providers at times can't find some pulse on somebody that's standing there talking to them. I've been in many cases where there was absolutely no possible way that the victim had or the patient had a pulse, and Highway Patrol were very excited, and they're like, he has a pulse, and he didn't have a pulse. He'd been hit by a car. His body is completely destroyed, and these law enforcement guys, they can't really handle themselves under these kind of situations. So anyway, no, there was no way he had a pulse. It was just a very heightened state. And so what he was doing is he's feeling his pulse through his thumb. He was using his thumb, using his thumb and his two fingers to check for a pulse versus just his two fingers. So he's feeling his pulse through his thumb in the heightened state. So anyway, if you don't definitely feel the pulse, you don't hear any breaths, and you don't see any movement, go ahead and start compressions. So patient assessment cardiac arrest, checking for a pulse in an infant, 0 to 1 years. You're checking for a brachial pulse. Everybody, the brachial pulse or brachial artery runs in between the bicep muscle and the humerus bone. Creates a little notch there. The reason that we're checking for there on an infant to 0 to 1 year of age is because these kiddos have little short fat necks. It's hard to even get in there and feel for a cardiac pulse. They don't have a lot of muscle mass on their arms, so it's very easy to find a brachial pulse. 2 to 3 fingers on the inside of upper arm, feel for 5 seconds to 10 seconds. Understand anytime per AHA guidelines, anytime that you go hands off on somebody, it is no more than 10 seconds, okay? So whenever you're doing your breaths, you're checking for responsiveness or anything like that, you're checking for at least 5 seconds, no more than 10 seconds. So if you get a question that said, what is the maximum amount of time that you check a pulse, or the maximum amount of time that you listen for respiration, any of that, it's going to be 10 seconds whenever the patient's pulseless and apneic or doesn't have a heartbeat and they're not breathing, okay? The chain of survival. Here's AHA's chain of survival. I've never really, bought into this. I've had my entire adult life. I've been in EMS, so I've always kind of been this effective advanced life support chain. So I've never really considered myself anything below that, and so I have a hard time remembering the chain of survival. Jacinda, I don't know if she could tell us if they're going to have any chain of survival questions on the test, but I'd at least kind of know that you're going to do immediate recognition and activation, early CPR, rapid defibrillation, effective advanced life support, and integrated post-cardiac arrest care. I might have a general idea of those steps, okay? Emergency care and cardiac arrest, activating the EMS system, adult CPR and chest compressions. After sir, are you okay? No response. That's the time to just go ahead, hey, grab the AED and call 911. Okay, so grab the AED, call 911. If you're in a crowd of people, whenever I'm teaching my classes, if you're in a crowd of people or you have a whole bunch of people standing around, be very directive. So call 911, grab the AED, or call 911, get the AED. You want to point somebody out, because if you just say it, you're going to have a delay because everybody's just going to stand around and look at each other for a second before somebody goes and does it. That's just human nature. Here's a diagram of good compressions. Their number here is wrong. This 1.5 to 2 inches is wrong. On the adult victim, you're going to do compressions to a depth of at least 2 inches and no more than 2.4 inches. Ridiculous. If you can remember at least 2 inches, you're golden, okay? If you notice their hands here, bottom half of the breastbone. The big thing is you want to stay off this xiphoid process right here, okay? Used to, they had us follow this rib cage up, 2 finger breadths above the xiphoid process and place their hands. Now they're just saying bottom half of the breastbone. That's good and bad. One, the good thing is you get in position really fast, but by teaching classes, even after describing that several times to students, they still place their hands down here, okay? So bottom half of the breastbone, bottom half of that sternum, okay? You want to be above that xiphoid process, and I believe you said it the other night, 2 finger breadths above that. If you know that technique, use that technique. I think it's a better technique than the bottom half of the breastbone. The way I've always done it, or ever since I've been in EMS, is I just use my middle finger on the nipple line where the nipple line should be. It typically puts me in about the right place to do good compression. So one thing that you do want to do is you notice that he has locked elbows. See how he's straight from his shoulders all the way through his elbows? Now he's able to do a weight transfer on the chest versus trying to muscle it. I see some guys in here that could probably get away with muscling it for a little bit. but I promise you, even being a big guy, you're going to tire out doing compressions. Okay, number one, you're going to have an adrenaline rush, and so all this epinephrine is going to be flowing through your body, and it's going to be eating up all your oxygen, and all of a sudden you're going to find yourself short of breath. And two, the chest is kind of it's kind of hard to press on. So if you do proper technique, you'll actually last longer and you'll do more effective compressions. All right. They're showing here this weight transfer. There, he's pivoting from the hips. Downstroke, his head's here. Upstroke, see what I'm saying? So at least 2 inches, no more than 2.4. I hate that they've done this because this has not been the correct depth. And I'm actually going to write the manufacturer of the book about this. I hate to think that they're going to have 1.5 to 2 inches on your test because it's wrong. That is the wrong depth. Now, if we're on a kid, it's approximately 1.5 to 2 inches. All right. No, not going to be near as hard. And actually, it's 1/3 the depth of the chest, approximately 1.5 centimeters or 2 inches.
Our book says 2 inches.
What's that?
Our book says 2 inches.
Yeah, approximately 2 inches. 1.5 centimeters is what I meant, or almost 2 inches. AHH says 1/3 the depth of the chest. Are you looking at your child? Is that what you're, or are you saying 2 inches for the adult?
Yeah, approximately 2 inches.
On the adult?
Yes.
Okay. The new verbiage, and you got to understand, this book was written before the 2015 guidelines. I will actually write Pearson to find out what guidelines they're using. If they switch to 2015 or they still using 2010, because the verbiage can mess you up. Approximately 2 inches and at least 2 inches are two different things. If they want to be. We talked about the hand position. We talked about the patient. Well, no, we didn't. Guys, I've seen this before. People try to do compressions on a bed. It doesn't work, okay? You want them on a solid surface. EMS-wise, I typically put my patients on a long spine board. They used to make what they're called CPR boards, or those short half boards to do compressions on. Anything like that will work. What you want to do is prevent that patient from getting a lot of that compression getting absorbed by the mattress, okay? If you're in a house or something like that, pull them off the bed and do compression on the floor. All right, the floor is going to be a solid place. Do not do it in the bed. Your depth, like I said, at least 2 inches. I would stick with that. The 2.4 is an asterisk thing in AHA, so they're at least 2 inches. And a rate, you're going to do the compressions at a rate of at least 100 compressions a minute. But if you see an answer that's between 100 and 120 compressions a minute, it's going to be the right answer, as long as they're using 2015 guidelines. But hopefully it's just at least 100 compressions a minute is in there somewhere. Why I say at least 100, because that's what it has been for the last, 7 years now. The 120 is new for 2015. The reason they want you to do a maximum amount is because, and I saw this in class, people do compressions and they would be going so fast they wouldn't allow the chest to fully recoil. Okay, and how you do that is you just you take all your weight off the chest. What you're trying to do here while you're doing compressions is you're trying to circulate blood, right? That's the whole point of the compression, is to circulate blood. So if you don't ever let that chest fully recoil, and you guys are mechanical, trying to think of something that if you don't let it fully recoil, doesn't fill back up with the fluid that you're trying to then compress around. And so that's why at least no more than 120. They find after 120, you're not allowing that full recoil. You're not allowing the heart to fill back up with blood. And so your compressions essentially are less effective. So, all right. So cardiac arrest here. Adult ventilations, open the airway, deliver 2 breaths with enough volume to make the chest rise. Okay. So in this scenario, or in this sequence, your compressor here is going to do his 30 compressions. And then the second rescuer, their main job is to maintain an open airway and give 2 breaths, or give breaths. So he's going to do 28, 29, 30. And the ventilator there is going to give 2 breaths over 1 second each, just until you see chest rise. Once you see chest rise, that's an effective ventilation, okay? No more. Call it good. Don't continue to breathe. You want to open the airway using a head tilt chin lift. which is just backwards downward pressure on the forehead, and you're going to lift the jaw using the bony part of the jaw. So one rescue adult CPR sequence. Check for responsiveness. If they don't respond, activate the EMS system. Call 911, get the AED. Position patient on a firm surface. If patient appears not to be breathing, check for pulse. That's actually incorrect. You're checking these steps at the same time now. This is a 2010 thing. And this happens for at least 5 seconds, no more than 10, okay? If no pulse, deliver 30 compressions, open the airway, and deliver 2 ventilations with a barrier device. Guys, do not give ventilations unless you have a barrier device, okay? We don't know these people. We don't know what they have. And OSHA, whenever I teach an AHA class, OSHA does not recommend you giving mouth-to-mouth without a barrier device. All right? Then repeat 30 compressions of 2 ventilation cycles until AED is available. Once the AED shows up, the person carrying it is going to place the AED while the person's still doing compression. So they're going to come on, they're going to power it on. First step of using the AED is to power the AED on. Okay, they'll place the AED around that rescuer as shown in the patches. Once the AED says analyzing patient, don't touch patient, then you're going to go hands off. Think about this. Your compression, you're only good at compressions for about 2 minutes. So that's probably how long it took somebody to go get that AED, right? It's about 2 minutes at least. So by the time they get back, you need to switch rescuers. So they put the AED on, don't touch patient, analyze the patient, you go hands off. Now you become that rescuer that's going to maintain an open airway and give breaths. The guy that got the AED is going to operate that AED. So analyzing patient, don't touch patient, shock advised, press red flashing button, shock. Now the person that shocked him is going to do compressions. You're going to do those compressions for 2 minutes. Okay, after that 2 minutes, the AED is going to come back on. It's going to reanalyze that patient. At that point in time, let's say it says no shock advised. Well, now you can check your patient. What they found is that if you do 2 minutes of CPR, even after you get a pulse back, there's a better chance of that pulse, you keeping that pulse, okay? Least likely for them to go back into cardiac arrest. Now I'm going to throw this out there because this can happen to you. You do some CPR, you get the AED on them, you shock them. Next thing you know, they're waking up and talking to you. I promise you probably shouldn't be doing compressions anymore because they're not going to want you doing. It's going to hurt, right? Yeah, exactly. They're going to get off me. And don't do compression. No, sir, I need to do this for at least 2 minutes. But leave that AED on them until EMS arrives. Okay. Once EMS arrives, they'll get them onto their monitor and monitor them. So
if somebody's touching, they're going to shock because it's reading.
Yeah, a lot
pulse, right?
of them, the algorithm will prevent it from shocking. It'll actually keep telling you, analyzing patient, don't touch patient, or touch patient, don't touch patient. Don't count on it though. Okay, I'm clear, you're clear, we're all clear. You look up and down your patient, make sure nobody's touching. Why? Because what's this AED designed to do? Does anybody know? Stop the heart. All right. So it's in these two lethal arrhythmias. The whole point of the AED is to stop the heart in hopes that the pacemaker cells will then take over and do it in a normal, what would be a normal rhythm. So put it back in normal sinus rhythm. So start with the SA node first and go down. But I don't think you guys will need to know all that. But anyway, I wouldn't count on it not recognizing you because if it does shock and does shock you, it can stop your heart as well. Okay. So AED doesn't play around. But yes, most of them will recognize that you're touching them. So have a rescue retrieve AED if necessary. Second rescue assist with CPR. Compressor will tire quickly. Decrease in the effectiveness of CPR will follow. It happens at about the 2 minute mark, research says. As ventilations are being performed, the second rescuer positions himself to assume compression. All right, so 2 rescue adult CPR sequence. Check for responsiveness. Activate the EMS system just like you did before. Position patient on a firm surface. Rescuers position themselves. Check pulse. Perform 30 chest compressions. Give 2 breaths. Repeat 32 cycle for 5 cycles or 2 minutes and switch roles. Okay? Every 2 minutes, you're switching roles. I'm going to throw this out there because we all work in rural America. There are AEDs out there that the algorithm is an old algorithm, it's going to be different than what the new ones are. Once you power that AED on, just listen to it and follow its voice prompts, okay? The reason that you need to follow its voice prompts is because it's going to start screaming at you while you're trying to do your thing. And so it's just easier to follow its voice prompts and just go with the old algorithm. It's okay. Not that big of a deal. So, all right. Two rescue adult CPR sequence. Monitoring the quality of CPR. Palpate a carotid pulse and chest rise. We're talking about this 2-inch depth of compression, guys. That's seriously, it's kind of hard to hit that 2 inches adequately. I don't remember if Leedy has it, but we have it over at Roger Mills, and various other EMS services have it. But it's a pump to do the compressions on. It's very useful. It tells you whether you're doing compressions deep enough, whether you're letting a full chest recoil, whether you're doing them fast enough, and it gives you voice feedback. But if you don't have something like that and you have a second rescuer available, if they can feel a carotid pulse or you're doing compressions, you're doing good compressions, okay? So have that person, whenever they're just sitting there twiddling their thumbs, go ahead and have them check for a carotid pulse to see if they can feel a carotid pulse. That's how we used to check it whenever on the ambulance service. So. Cool. Question? So, something else I forgot to tell you. Tomorrow I have an EMS board meeting. Well, before I forget, please come in and start going over the review questions with each other. Same with you, Leedy. I won't even start the video conference until I get here, just because I don't want to put that on you guys to try to figure out how to do it. And plus, I don't know if you guys have a computer that would do it. I don't know. Oh, okay. But anyway, it should be between 7 and 7:30 when I get here. Please come in. Please start doing the review questions. Have some questions for me when you guys are going over it. Okay. I almost forgot about that, but I have that EMS board meeting. So, signs of return of spontaneous circulation: spontaneous breathing or gasping, patient movement, patient swallowing, consciousness. If you're working with a service that has end-tidal CO2 or waveform capnography, Leedy, you guys do, you will see a spike in that waveform. So their end-tidal CO2 will probably be sitting around 8 to 10, maybe even a little lower. If all of a sudden you see that number, that waveform capnography, that end-tidal CO2 jump to 25, there's a good chance you just got a pulse back. And it's before anything else is going to know it. Waveform capnography is the first thing to find it. All right. So be aware of that. So complications of CPR, fractured ribs and collapsed lungs. I'm gonna put this out there. I hear people and I cringe when they say this. If you're not breaking ribs, you're not doing good compressions. That's not true. If you're breaking ribs, you're doing compressions too deep. You will hear cracking or when you're first good compression. That's just separation of the cartilage of the sternum. Okay. After that, if you hear a snap, and that snap will be more over towards the side, if you hear a snap, you just broke a rib. Just back off a little bit, okay? You're not going to hurt them any more than they're already hurt. They're dead, right? It's hard to hurt you any more than dead. But if you do get them back, you may, collapse a lung. It might be have that in the back of your mind. The only caveat to that is if it's your little old people, your little old lady, your little old man that has osteoporosis, every time you do a compression, to get it deep enough, it's going to break. They're so brittle. It's just part of the game. But understand, you get that 30 to maybe 60, depending on their health condition, late 60 guy or lady, and you do you're going along, and all of a sudden you hear a snap. You're going a little too deep. Back off, okay? That's all you need to do. Don't stop compressions. Just back off on your depth. So, adult CPR key points. Recognize and activate EMS early. That is key, especially for a layperson. If you guys are out in the public and you come across somebody, early recognition is key. So push hard and fast. For the people that are planning on just sticking at the EMR level, not going on, the first time you get in a situation where you do compressions, it's going to be a big mind fuck. Have you had to do compressions yet? Could you remember all your numbers and stuff when you no? You're going to be lucky if you could even remember the word compression. But if you could get in a good position and remember to press hard and fast, you're going to do so much better for that patient. Okay. EMS is going to come along and say, hey, good job. And one of us will probably take over. Hey, do you mind hanging out and working with us? Because here's the thing. If we have an ALS personnel on, the ALS person wants to intubate that patient. They want to start an IV. They want to get meds on board so we can get them out of these rhythms. And so it's a lot of help if you and like a basic or you and another person can alternate compressions while I do my intubation, intubation is one of the last things I'll do, but while I start my IV and get my meds on board, and then advance or secure my advanced airway, it'd be a lot of help if you're there and you're doing good compressions to help us out. So switch compressors often, 2 minutes, every 2 minutes, guys. Once you get the AED on with a new algorithm, it will analyze every 2 minutes. Okay, switch rescuers. If not, kind of be aware of your time, and don't be a hero. Okay, don't whenever somebody says, hey, I'll go ahead and take over compressions. Let them take a breather. Okay, I've been on lots of codes where people are like, no, I'm fine. They're doing compressions for 10 minutes. Like, no, seriously. No, and I remember these days. They were before we found out that we tired out after 2 minutes. But now seeing the research, the study behind it, yes, we need to be switching every 2 minutes, if at all possible. I understand that it's not always possible to do it at the 2 minute mark. Okay, limit interruptions and compressions. There's some studies out there that show, and guys understand whenever they're talking about these percentages and stuff. Anybody know much about statistics? So in statistics, there's always outliers. Okay, and so whenever I say things like, if they have a total of hands-off time of 10 minutes, they have a 0% chance of survival. No, there's always outliers. So there's people that they went greater than 10 minutes. They're submerged in water for over 40 minutes. They don't have any. They have all their brain function. They make a full recovery. There's those outliers. I'm not telling you not to do it. I'm just telling you to be aware of what you're doing. Minimize your hands-off time, because if your hands-off time equals 10 minutes or greater, they have a 0% chance of survival. Okay, I understand that with this, what I just said with the statistics thing. So the response: bystanders at the office frantically wave you in. That's very common, even whenever they stub their toe. You grab a portable suction device, a backboard, and your response bag. You arrive at the patient's side to find two bystanders performing CPR on a 58-year-old woman. So, as an EMR, is there anything else that you would want to grab, or do you think that guy kind of grabbed it all? It'd be nice if you had an AED, right? As an EMR. I don't know what your guys' status is here at the fire station, but if you guys do become an EMR agency, you probably ought to seriously look at spending the $1,200 or $800 to $1,200 for an AED. For the fire departments, I preach it this way, and you guys on volunteer fire departments, and I'm one of you guys with Berlin. We don't always live the most active life. Our lifestyle is not a firefighter like in Oklahoma City, where those guys work out every day. So we're not the fittest people. Okay, so then we go throw on this hot bunker gear, and we lose all of our electrolytes. All right, now we have this epinephrine with this adrenaline rush because we want to fight a fire. It's a recipe for catastrophe. Okay, and if anything, get an AED on your rig to save your own guy. Okay, because a lot of times whenever you have that recipe, if you can get them shocked back quick, they're going to make a full recovery. Okay, so that's how I preach it to you fire guys. It could say save one of your own. Coworkers state that the patient had been feeling sick all day and passed out at her desk. That's not good. No pulse is present when you assess. Compressions are continued as you attach an AED. Before we go into pediatric CPR, I know that this isn't necessarily the chest pain section, but it is cardiac arrest. Some other things for you guys to kind of look at whenever you're go and look at this person, just to have in the back of your mind. A heart attack can present from anything from just I don't feel right to the classic sweating, diaphoretic, pale, chest pain, radiates into the jaw and left arm. Okay, so typically you have the little old lady. Sometimes the only complaint is, I don't know, I just don't feel right. We run a 12 lead on them, and they're having a big old MI. Okay, so understand, always be prepared for it. All right. So here's a pediatric chain of survival. Remember, I told you most common cause for pediatric to be in cardiac arrest is an airway issue. All right, they have them in a seat belt, so we're preventing that trauma. But the first thing is prevention. The parents having the EpiPens, knowing their allergies. If they're asthmatic, staying on top of the asthma and all these other things. Early cardiopulmonary resuscitation. You notice that this early cardiopulmonary resuscitation is before the prompt access to emergency response system. The reason is because the most common cause for a child to be in cardiac arrest is an airway issue. If you come along and you find a child and you start compressions and ventilations right away, you give that kid a better chance of survival than if you delay that treatment. So AHA standard or guidelines are, if you find a kid, you're going to do your 2 minutes, approximately 5 cycles of compressions and ventilations, and then go call 911. All right. Now, obviously, if you're with a kid, they collapse, go down, call 911. AHA just this year has started teaching something that I've been telling my students forever. We all have friggin' cell phones with speakerphone. 911, speakerphone, throw it down next to the kid, talk to the operator while you're working the kid. Okay? The best that you can. Obviously, this is a very traumatic situation. So, prompt access to the emergency response system, rapid pediatric advanced life support or PALS, and then integrated post-cardiac arrest care. Resuscitation now, call later. That's what I just told you about, is that you're going to start your resuscitation effort before you call 911. Airway and breathing problems, start CPR first, then call for help. Immediate CPR is the best chance of survival. I kind of already ran that down for you guys, right? Pediatric compressions, patient position, once again, we're going to put them on the hard surface on their back. Hand position, same place, bottom half that breastbone. You do have the option on a small child to do one hand compression. The only thing I'd correct in this guy here is he hold that airway rather than lean on that arm. Hold that airway into an open position versus just let that kid's head flop around. So keep that head in that neutral inline position, or it like this one shows a very slight sniffing position. All right, keep that airway open with your other hand.
So you can lay him on a towel like your son's son.
And then are you looking at an infant there?
No, it's same kid, but it looks like
Okay.
you got a towel under you.
Yeah. So what the towel does is it gives it just enough lift to the shoulders to drop that head into that sniffing position, just a little bit of head tilt, if you will. They're starting to go more to that neutral position. But if the EMR book is telling you to do the sniffing, a sniffing or slight tilt, then do it. And the best way to do it is to use a towel under the shoulder. It just drops the head to the perfect place. So your hand position, like I said, is still in the same place. Your depth is 1/3 the depth of the chest, right about 2 inches, or approximately 2 inches, or approximately 1.5 centimeters for all you English folk out there. What do they call that? The standard measurement? No, metric. Metric. So anyway, rate, you're still doing a rate of at least 100 compressions a minute, no more than 120. Difference is whenever you have a second rescuer, you're going to go from that 30 compressions and 2 ventilations that you do as a single rescuer to 15 compressions and 2 ventilations with your second rescue. Okay. There you go. There's your picture of the towel under the shoulders. Very slight sniffing, but that picture almost looks like it's more in line than anything. The other kid's head wasn't in line. So pattern on the torso and opening the airway. Guys, it just keeps that airway open in that open position. Use it's not to facilitate the compressions or anything like that. It's for your airway. Okay. Use appropriate size equipment. Well, what they're talking about there is if you have a bag valve mask, you want to use a child or infant bag valve mask on the child or infant. Do not use the adult size bag valve mask on them. It's going to be too large. You can end up causing lung damage. Ventilate over 1 second, just enough to make the chest rise, just like we were with the adult. Allow for adequate exhalation, so get your 2 breaths. Take the number that's in the book. Let me write them and see what they want me teaching, because now rescue breathing is that you. Rescue breathing is a saying. We're listening to a page. I was telling.
I'm like Eric.
So your rescue breathing for everybody now is 1 breath every 6 seconds. So I'm going to write them and just kind of ask these questions on what they want and see if I can get a response. They're gonna go and they're gonna run this cardiac arrest, or knowing Eric, some sort of drug overdose. So, 1 rescue pediatric CPR sequence. Check for responses and signs of life. Physician patient, check pulse, deliver 30 compressions, open airway, deliver 2 breaths. Repeat the 32 compression until to 30 compressions to vent. Oh my gosh! Repeat the 30 to 2 compressions to ventilation cycle until EMS arrives. So on the infant, the child, you're going to check the same. Everything that how you check is going to be the same on the child as the adult. On the infant, you will change it rather than shaking the shoulders or whatever. Hey, you okay? You're going to tap the foot. Baby, are you okay? No response. Help, call 911, get the AED, check under the brachial versus the carotid. We already talked about that. All right. 2 rescue or pediatric CPR, check for response and signs of life. Kind of the same steps here. Activate EMS, position patient, position rescuers, check pulse, deliver 15 compressions, open airway, deliver 2 breaths. Repeat 15 to 2 until EMS arrives. All right. We already kind of talked about this stuff. Alternative compression technique for newborns and small infants. This isn't really alternative. It's the preferred method if you have 2 rescuers. You're going to use the 2 thumbs encircling hands technique. We didn't really go over the compression, how you're going to do compressions on infant. You're going to take 2 fingers and you're going to find their nipple line. And it's 2 fingers, and you're just below that nipple line is where you're going to compress. Okay. Once you have that second rescuer come in, you're going to do the 2 thumbs encircling hands technique. Basically, you're going to have your hands encircling the infant with your thumbs just below that nipple line, and do the compression in the same place that you did the 2 fingers. Once again, it's 1/3 depth of the chest, approximately 2 inches. They're saying at the nipple line. AHA says just below. So, encircle the torso of the patient with your fingers. Squeeze. Perform compressions. Allow for chest recoil, or allow for full recoil of chest. So, once again, complications of pediatric CPR: fractured ribs, collapsed lung, and hypothermia. Unless you're running an induced hypothermia protocol, guys, you probably try to keep your patients warm. Okay. AEDs. Once again, I think AEDs and layperson CPR is the bee's knees to saving people. AEDs are very easy to use, very self-explanatory. If you just swallow your fear and do it, okay? Your first step of operating any AED, because every AED is a little bit different, your first step is to power the AED on, okay? Find that power button. Some of them you simply lift the lid off and it powers on. Almost every one of them, especially public access, then has a little dot or some sort of diagram of where you're at in that sequence, and it'll walk you through everything you need to do. Once that AED is powered on, just listen to its voice prompt. I'm going to see what they say here. So, you can use the child pads on the adult, or sorry. You can use the adult pads on the child, but you cannot use the child pads on the adult. The child pads have a dose attenuator, so it reduces how much electricity is delivered. It's typically not going to be enough to defibrillate an adult, but the adult pad's going to be plenty to defibrillate a child. Okay, if they have a hairy chest, try to find a way to shave it. Okay, sometimes you might get in the heat of the battle, you put it on the hairy chest before you realize it's a hairy chest, and your AED will tell you check pads. Put some more pressure on those pads, see if you can get it to make contact. If you can't, rip that pad off if you have a second set of pads. Okay, and then see if you have a razor. I use, for my unit service, I found a single blade razor works the absolute best. I don't remember the company that makes them, but you just take a little cardboard thing off, has a little handle, it's just a single blade. They don't clog up like the disposable Bics. I don't have, I think, a sanitary issue that the reusable medical electric razors have. It's a one use, it's disposable, it works awesome, and it doesn't clog up. So shave the chest. If they're wet or in a puddle of water, remove them from that puddle of water, dry them off. Okay, it's not that it's gonna shoot sparks everywhere or anything cool like that. It's just gonna defer the shock from where you wanna go. The electricity is probably gonna follow that water across the chest versus going through the chest. What is electricity like? Aren't you electrician? What is electricity like? Yeah, path of least resistance, right? So, hey, this is the easiest way electricity is taken, right? It's a conductor or it's a ground force or whatever. Right? So, so if that easiest path is across the skin because of water, then it's going to do that. So, if arrhythmias cause a patient to go into cardiac arrest, asystole. This will not be shock. Okay, this is what we know as flatline. You trying to catch him up? So, pulseless electrical activity, guys. You're not read monitor, so this one really doesn't even pertain to you. But I'll tell you what it is anyway. A PEA or pulseless electrical activity, it can look like a normal sinus rhythm or what your heart normally looks like. The only thing is whenever I check for pulse, I don't have it. It means that the electrical system's working, but the muscle's not contracting as that electricity goes through the heart. So you don't have contraction with the PEA. Ventricular fibrillation. It's just quivering. It looks like a big mess on the monitor. And then ventricular tachycardia. Understand something. Do not put an AED on somebody that's sitting there talking to you complaining of chest pain because you think they might go into cardiac arrest. Ventricular tachycardia is one of the rhythms that the AED will shock. Okay? And you can have a pulsatile VTAC or a pulseless VTAC. Okay? The only reason the AED knows the difference is because you checked for a pulse and they didn't have one, so you applied the AED, so it's going to shock that rhythm. If they're sitting there talking to you and for whatever reason it shocks, let's say that you have a true AED, a true automatic external defibrillator, there's still some out there, and it delivers a shock, and it does it at the wrong time, you can cause an R on T phenomenon, and you can put them into asystole, and you will never get them back. You can never get them back once that happens. So, so please, if they're sitting there talking to you, don't put an AED on them just in case. Maybe have it ready just in case, but don't put it on because this ventricular tachycardia, which just looks like a big wave, looks like your radio waves, kind of. For the guys that have know what radio waves look like. That's what it kind of looks like on a monitor. It's even and across your your monitor. They can have a pulse with that. They can be talking to you with that. So AED safety, apply only to pulseless patients, as I just said. Shock can be harmful. It's designed to stop the heart, guys, and it can hurt like hell if it doesn't. Have you ever seen an AED work? Okay, and what they go, they jolt, and then obviously you want to clear the patient. So I'm clear, you're clear, we're all clear. So attaching the AED, as you see here, it has a picture where they want you to patch it. Pay attention to these pads. Can you guys see this red arrow right here on this AED pad? Okay. That means that once this patch right here. Now, I'm going to tell you something. There are AEDs out there, and Cardiac Science makes, in my opinion, one of the best public access AEDs out there because it doesn't care which way you put these pads. You could interchange in between these two positions, and it doesn't care as long as you just put them in the right position. And it's going to read it either way. Okay, and I like that because in classes I've had before, I'll have a student come up and put an AED on while I'm doing compression, and I'll tell them, place patches exactly shown in picture, and they flip them. Well, if it's an AED that cares about that, it may not work. I'm not going to say it's not going to because the algorithms are pretty good these days, but it's going to have the best chance of working correctly if you put it in the position shown in the pad. So operating an AED, turn on AED, attach pads to chest, clear patient and analyze rhythm. If shock advised, clear patient. Press shock button, resume CPR immediately after shock. I'm glad that they got that in there because I think it's important. I'm going to go ahead and throw this caveat out there though. Listen to the AED prompts as they go. But for testing purposes, resume CPR after you deliver a shock, okay? AED use with pediatric patients. There are pediatric pads, front and back placement, if you need to. What they're diagramming here is they want this one moved up to the front and this one around to the back, okay? Why you would do that is because you have your pads are the infant's too small. Your pads are touching or overlapping. You do not want your pads touching or overlapping, okay? If they do, use this front to back placement. All right? Cool? Cool. So, continuing quality assurance. All AED calls should be reviewed. I'm not going to get into what your guys' policies and procedures should be, but if an AED is used, you probably should be reviewing it. Data is used to improve performance and routinely check your AED. That's another reason I like the Cardiac Science. It checks everything from the gel and its patches all the way down to its batteries. And it has a little green globe on it, and green means go. And all you got to do is take a look at that globe. Even if those patches are out of date, they're still good enough to defibrillate that AED checks it. Now, obviously, you should have some sort of procedure where you check dates and things like that and change your pads out. Whenever they're coming up to expire. But that's why I do like it for public access. You have the public access AEDs tend to just be put up and forgot about at times. And if you have that green globe sitting there and all of a sudden it's a red X, that's very noticeable as you walk by. So putting it all together. So one rescuer adult CPR. Observe patient for signs of lifelessness. Scan chest. I'm going to add one step in before that. Whenever you first see a potential victim, make sure your scene is safe. All right. You don't want them to be lying on a hot wire. You don't want them to have been mixing chemicals or anything like that, and then you become a victim yourself. Make sure that scene is safe. Or you don't want them to be have been shot and then somebody be standing there with the gun ready to shoot you. All right. I'm sure it's trying to hit everybody's profession here. You don't want them to have eaten a burrito. No.
After eating one of my burritos, I don't know what happened.
You're not guilty.
I'm not guilty.
All right. So make sure the scene is safe. Always make sure the scene is safe. Just get in the habit of saying this: gloves on, or BSI, or PPE, and scene is safe. Basically, you want to take body substance isolation or personal protective equipment, and you want to make sure the scene is safe. You want to take care of yourself, number one, and then your partner second, right? After that, observe patient for signs of lifelessness, scan chest for breathing, activate EMS system, request advanced life support assistance. Here, we don't really have much option. Send us whatever you got, please, now. Send someone for an AED if one is not present. And you could actually do that. Call 911 and get the AED. That's how AHA teaches it. And move the patient to a firm surface. Check for a pulse up to 10 seconds, at least 5 seconds, no more than 10. If no pulse, oh gosh, I'm going to tell you, start compressions. If there's no pulse, start compressions. Once the AED becomes available, attach the AED there. I didn't read it all. So attach the AED or begin compression. Begin compressions. Do not delay compressions for the AED. Have somebody running, unless you're by yourself. All right. You know there's one 30 steps, 45 steps away. Run over there and grab it. But don't delay compressions while somebody's going to get the AED. Perform 30 compressions and then 2 ventilations. And then continue CPR and follow prompts on the AED. I'm glad that they put it in there like that, to follow the prompts. Return to spontaneous circulation. If CPR and defibrillation return a pulse or cause spontaneous breathing, continue rescue breathing if necessary. The new guidelines are 1 breath every 6 seconds for everybody. The old guidelines for pediatric patients was 1 breath every 3 to 5 seconds, or 1 breath 6 to 8 for adults. Okay. So I gave you 2 different versions there. Don't mix them up. So if you need to write them in your book, I'll give you time to write them in your book. But you'll need to know them. I'll almost guarantee you. So apply high concentration oxygen. Monitor the pulse carefully. Keep AED pads attached to the patient if protocol allows. Yes, keep AED pads attached to the patient. If EMS arrives and we cancel the code, we're leaving those pads attached to the patient. We'll let the ME or the ME assistant take those pads off. Okay. The only time you're going to take them off, or somebody to take them off, is if I have a different monitor than you do, and I'm going to be transporting the patient. I'm going to take your pads off and put mine on. I highly recommend if you guys go ahead and get an AED, you work with Signer and see what kind of monitor they have, and see if it's a standard monitor for their service. When I was there, Signer had about 3 different monitors. They had Philips. Sorry, they didn't have Philips. They had Physio Control and they had Zoll. So there's no standardization, so it wouldn't help you out. The reason I say that is because if you, let's say that they have Zolls, if you buy a Zoll AED, they show up, they're able to unplug from the AED and plug right into their monitor, and we don't have to change pads out. So ethical considerations of cardiac arrest. Don't fight with the victim's family. All right, now, I don't know what's going on there. That's what it looks like. Don't do that. Oh, you're a cop.
We showed up and the guy was blue, cold. He's been there probably all night.
Yeah.
They wanted us to do CPR.
You're like, nah.
They wanted us to do CPR. I told them no. And then they started talking about how we don't care and we'll work with this shit.
Of course, you're a cop. That's, I mean.
Okay.
Here's another thing, guys. Babies are bad. It's a bad day. But if they have rigor mortis, leave them in the crib, please. Please leave them in the crib. I don't want them.
Don't worry. That was one of my worst calls.
No, I had a firefighter hand me a stiff baby with blood coming out of the nose and stuff. And I'm like, I don't want that. Put it back in the crib.
Okay. One of them on 9th Street, I did CPR and we lost him.
Yeah.
And the other one was over on 2nd Street. We were able to save that.
No, if they're warm, go to town. But if they're stiff, leave them. The thing I was worried about in that one was, are we dealing with shaken baby or something like that? And now we remove that baby because there's blood coming. There's quite a bit of stream of blood, and I understand that sometimes you can see that with SIDS. To my understanding, but I'd rather the ME or ME assistant and the law enforcement guys have everything they need if they're going to have a prosecution on that. So anyway, obvious signs of death, rigor mortis. Everybody knows what that is, right? Stiffening of the body. Understand there's a time frame that rigor happens. And if they start rotting, yeah, they're way past that, okay? When I'm not doing CPR on the rot. Do you smell the dead body yet? A really ripe, rotten one? Yeah.
He died in his chair like this, and when we went in the house, his face was here.
Nice.
So, yeah,
And the smell was awesome, wasn't it?
yeah, it was pretty bad. We ended up putting on SCBA.
Yeah, I think, and this is just kind of a gross side of the class. I think a rotten human body is probably the worst smell I've ever smelled in my life. And mine was she had died. So it'd been hot for about 2 weeks, and it's that spring time of the year where it's hot, cold, hot, cold. Well, it'd been hot for about 2 weeks, but the heater was on, so I know that she had been dead for at least 2 weeks. But she was bloated and splitting, and there's already maggots eating her legs. And in Wichita, they required EMS to verify all deaths, no matter how obvious it was. Yeah, and we get out, and not even kidding, at the curb, I could smell it, and I was like, oh, nope. And I was a student at the time. They're like, student. And I do not do well with smells. I don't. And so I went in to check her out, and she didn't need to be living by herself anyway. She'd been peeing and pooping in her house and walking through it. There's trails throughout the house. And go back to where she was. She died in between her bed. She must have rolled out of bed or something. But her bed was sunken in. There's no sheets on it. She'd been peeing and pooping in her bed. And she's laying there beside her bed, bloated up as high as the bed and splitting. And I was like, yep, she's dead. I turn around and I'm headed out because I held my breath this whole time. Headed out, and I get to the door, and I was out of air. I had to take a breath, took a big old breath of that, and I came out, and I was driving, and I felt bad because one of her family members was standing there, and I just like, I'm sorry. Yeah, because it smelled so bad.
We had one down at the apartments here. We wanted to move them. They've been dead for a couple of weeks or whatnot.
Yeah.
To move them, and guy was with me grabbed their arm, went to pick them up, and the arm goes.
Yeah. Yep.
We just set it back down there.
So don't do CPR, the gross dismemberment, including decapitation. Don't do CPR on these people. A better example of what not to do CPR would be, let's say that you show up at a car wreck and you have, let's say, a partial decapitation where maybe the top of their head's off and it's cut off their brain, cut off the top of their brain. Don't do CPR on that person. You can't save them, okay? I say this not because I think that you guys are going to go out and do it. I say this because it's been done. And EMS crews will show up, and depending on your protocol, if CPR is in progress, you have nothing else to do but run the call. Now, I've given my people, call a doctor, stop that, because there's no reason to put you mentally through that, to go through that. I mean, it's bad enough to go pronounce them, but to do compressions on it and watch every last ounce of blood that they had squirt out into the back of your ambulance because you can't contain it. There's no need for it. So, and do DNR orders. We talked about DNR orders. Sometimes they get to some heated debates, even without law enforcement there. If it ever gets to the point where you feel that you're in danger, retreat and get law enforcement involved. But if they have a valid DNR order, and in Oklahoma, I believe it is signed by a physician and in date, you should do your best to honor it. And if the durable power of attorney tries to override it, or somebody that's there tries to override it because of the emotion of the situation, you should really try to talk them out of doing that. It's my understanding we will run it if they absolutely have to, but typically once we get out in the ambulance, we'll kind of stop until we get to the hospital. So, and then they typically will honor it they'll honor it in the hospital. So, I actually had a lady one time. We were in an old man at a nursing home, and I always ask when it's a nursing home, do they have a DNR in their file? No. Okay. And so I get him back. I'm so dang excited because it was actually my second code save. The first one that I had gotten where we actually were responding from the station. The first code save I had, we were pretty much at their house and it went out. But so I was pretty excited about the whole situation. We got him back. He got to where he had purposeful movement, so his brain was still there. And his wife shows up, and she put him in the nursing home, and she was so pissed. He had a DNR, and you know I was taken aback, but the doctor was like, "Ma'am, I understand that, but they didn't present it, and we have a pulse and he's breathing. There's a good chance he's going to live. Do you want us to stop everything?" Yes. So they put him up on the ICU on oxygen, and he died. I think it was like 12 or 15 hours later. You know, and it's like, wow. Guess she had other plans than him living. So. I know. I will haunt my wife if she does that shit to me. So, all right. Transition. You attach a AED and turn it on. Shock advised. You press shock. CPR is resumed. No change in patient's condition. Paramedic arrive and you give a report. They continue to work on the patient, delivering another shock and starting an IV and administer cardiac medications. So, guys, I'm not going to speak for every EMS provider out there, but if you identify yourself as an EMR, or even sometimes if you are displaying that you're able to do good compressions and you've kept your composure, I'm going to ask you to stick around and help me out. I'm not too big to ask for help on these codes if I'm shorthanded. So, and I greatly appreciate it the people that do stick around and help. So define the following terms: atria. Do we know what the atria are? Basically, they're chambers of the heart that feeds the ventricles, right? So they pump the blood into the ventricles. There might be a better definition in the book. I'm not sure, more precise. What did it say? Upper chamber. And so they're calling the ventricles lower chambers of the heart is all they're doing there in your book? Cool. Pulse. I'm going to say that it's a palpable heartbeat. You could feel the heartbeat. Let's see what they're. Who's that? Cardiac arrest. Yeah. Apnea. Not breathing. Agonal breaths. Let's look at a definition of agonal breaths.
Infrequent, irregular gasping respiration, usually associated with respiratory cardiac arrest.
Yeah. I'm gonna give you a number, or I guess maybe an image. Think about a fish out of water breathing. That's typically the person. They call it guppy breathing.
We got a guy that ran from and he ended up going all the way to Texas. He tried to take the deputy's gun.
Oh, whoops.
The deputy shot him in the head. And I mean, you couldn't see the bullet hole here and the exit here. And when I got there, he was.
Guppy breathing.
And then when their EMS showed up, they started CPR. But you knew there was no saving him.
They must have had a protocol. Because I would have said even if he was still in agonal respiration, that's signs not compatible with life. Most likely they're not going to harvest him.
When I showed up, the breaths were like every about 2 to 3 seconds.
Yeah.
When they showed up, they were more like 6 to 8 seconds apart.
Yeah. Those breaths will get further and further apart as more pressure is placed in the brainstem. It's going to take enough pressure in that brainstem to shut down that acoustic center, so or the breathing. So cyanosis, we've said that, we defined that several times. It's just blowing around the lips. AED. What does AED stand for? Okay. I want you guys to understand something. Most everybody today uses an S AED, a semi-automatic external defibrillator. The difference is a true AED, and I told you there's some out there, and once it sees there's a shock, it'll say shock advised, shocking patient, and it'll do a countdown, and it's going to shock that patient. An SAED, you have to actually push the button to shock it, okay? CPR, what's it stand for? Cardiopulmonary resuscitation, right? Cardiac and lung resuscitation, you're doing both, right? Xiphoid process, what is that?
The small
Thank you, Jacinda.
end of the sternum. Yeah.
Yeah, it's a piece of cartilage that hangs down, looks like a little mini finger projection. So, arrhythmia.
Abnormal electrical heart rhythm.
Abnormal electrical heart rhythm. Yeah, and guys, there's some arrhythmias you'll never know they have. There's a chance that some of you in here walk around with an arrhythmia every day of your life. There's just some lethal arrhythmias, and that's what we're more concerned with. Defibrillation. Shock applied to the heart, yeah. And that could be through an AED or like EMS, we carry defibrillators. You have to be, I believe in Oklahoma, you have to be a paramedic to use the regular defibrillator. Kansas, they had IDs or intermediate defibrillation techs. So I'm PAD. Okay. Public access defibrillator, is that what it is?
Yeah.
I call it just a public access AED, but they're calling it public access defibrillator. Rigor mortis. Yeah. Dependent lividity. We didn't really talk about that.
That's when the blood pools.
Yeah. Yeah. Any like if they're sitting in a chair, the dependent lividity is going to form on the bottom of the arm, on their butt, the bottom of their legs, and on their feet. Bones. See, it taught you something.
I like bones, I'm sorry.
I had a patient. I had a patient one time that had dependent lividity, so I was going to call it. And but I looked at him, and they're sweating. Oh, this is freaking weird. So we went ahead and run it, and it was an asystole code, which I expected that. My partner went ahead and I stepped out of the room and started getting termination because asystole dependent lividity. We should have been good. As I'm asking for orders not to terminate the code, my partner's like, no, we got a pulse back. So yeah, it was weird. Now he ended up dying, but what it was, and we had this dead body in asystole with a core temp of 106. Yeah, nothing fit. What it ended up being is ecstasy. Yay, ecstasy. They fried themselves is what they did. So.
We got pulled guy out of the freezer again one night. All of a sudden, he stripped down to his skivvies and sit in the freezer. It was so hot.
I don't need any of that. Whatever it is that you took, I don't need any of it. So the upper chambers of the heart are called the atria. Yeah. Good job. The left blank pumps blood to the body. Yep, ventricle. A bluish tint to the skin, especially around the lips and fingernail beds, is known as cyanosis. The appropriate rate of compressions for adult CPR would be blank per minute. Yeah, 100 per minute. Good job. Be careful whenever you're doing your test. You'll have 32 in your head. I promise you will. Don't put 30 there, okay? Read the question closely. Blank per minute, okay? I know that because my thought whenever I first read it was 30. All right? So we've talked about all these things. We discussed the importance of uninterrupted CPR while we're talking about it. So basically, you give them a better chance of survival, right? If you have less interruption in your CPR. How do you determine your effectiveness of CPR? What's that? Oh, I thought you said it. Carotid pulse. If your second person can feel a carotid pulse, you're good. I'm going to give you another thing. The times that you've been involved with a cardiac arrest, whenever they are dead, you knew they're dead, right? You look at them, they don't have any color, they look dead. Whenever whoever started doing the compressions, all of a sudden they look like they're alive again, right? They also
Their color would come back.
Yeah, their color comes back. So that's something else to know that they're doing effective compressions. Their color comes back. So when should you deliver chest compressions to a pediatric patient? Yeah, immediately. So, and here's another thing, because you're going to give them the best chance of survival if you do it. I don't know if they're going to have you know this, but this is part of the BLS course, and I think that anything like BLS related will end up being fair game. If an infant has a heart rate below 60 beats per minute, and they're not breathing, and you attempt to ventilate that patient, and that heart rate doesn't go above 60 beats per minute, you're going to do both compressions and ventilation on the infant, okay? If it's above 60 beats per minute and they're not breathing, you're just going to do the rescue breathing, okay? That's on infants. The reason I want to tell you that, after I seen that, I thought about it, is because it is part of the BLS class, and I'd hate for you guys to get a question like that, because you're supposed to know the BLS stuff and not have been told that. Discuss the safety precautions you should take when using an AED. Yeah, clear your patient, right? Yeah, remove sweat and water. Some other things, they have a medicine patch. You can remove that medicine patch and wipe it off. Don't place it on any implanted device like an implanted defibrillator or
Nipple ring.
What's that?
Nipple ring.
Nipple rings. Don't place it on a nipple ring. That wouldn't be good. Somebody asked me, do you need to take the nipple ring out? Not necessarily. You just don't want to place that AED on it. Yeah, that would be a bad deal. So. All right, that looks like all 60 slides for this chapter. Let's take a little bit of break, and then we're going to come back, and maybe you guys could, for the people that showed up a little bit late, hang out for a second. I'll just kind of tell you what the next week's going to be like. But whenever you guys come back, maybe we could work on some end of chapter questions. I still want you guys doing end of chapter questions. I still want you looking at rationales and the reason you miss it. Try to take it like you would a test. Just go through, answer them, and then go through and check your answer. You have a question?
On this question, I probably missed it, but it says on performing 2 rescue adult CPR and recommended that you switch compressions every, the correct answer is 5 cycles in 2 minutes.
Yeah.
And I put 4 just thinking you're 30 seconds.
You did the math.
30, yeah, exactly.
You got to remember that your compressions are at a rate of 100 compressions a minute. So your 30 compressions is not 30 seconds.
Right. Yeah.
So does that make sense?
Yeah.
30 compressions every 23 seconds.
You know what it is. Did you do that in your head? Because okay.
But I was curious.
Yeah, it's and I'm that's probably my bad. I should have mentioned that. It's 5 cycles. It's approximately 2 minutes. Whatever you're talking.
There's a question.
Whenever AHA it says 2 minutes, they've always talked about 5 cycles. So hand in hand. So my bad. So
One of the questions says you're walking through a park and you find a guy down or looks like cardiac arrest. Nobody else is around, and nearest AED is at least, I think it said 5 to 8 minutes away. What should you do?
wow, that's a tough
I
one.
mean,
Well,
nobody else around. It's just you and the patient.
by the time you get back, what is that? 10 to 16 minutes? Or
Yeah, and if you start doing compressions and nobody comes around, 2 to 4 minutes, you're done.
you're done. Yeah. I mean, all you can do is go get help. So what was the correct answer on that one?
There's not. I didn't look up in the back of the book.
Oh, okay.
Yeah.
No, that's a good question.
One of those that scream and holler.
Well, then they need defibrillation. So I'm gonna guess that their correct answer is you're gonna go get that AED.
Yeah, at least 5 minutes away. The nearest phone is at least 5 minutes away, but there's nobody else there. Doesn't say the AD, it says the nearest phone is
Wow.
5 minutes away.
Well, you need help and you need an AED.
I think if you see him, I'm already on the phone.
It's crazy.
That's why I said, how could a phone be 5 minutes away when everybody has a cell phone?
I know, right?
Yeah.
All right, so the people that showed up a little bit late, we were gonna finish chapter 8 tonight. The plan is to take our test next Monday. If you guys could buckle down, read your questions, do your answers, we could do maybe some discussion Wednesday, but the rest of the night and tomorrow, I want to, just kind of randomly hit some review questions, have you guys answer them in class, talk about them in class. Wednesday, I would like to probably hit at least one new chapter, if not two, but answer any questions you guys have. Feel free while you're studying. If you don't understand, shoot me a text. If it's kind of late at night, if some people are night owls, shoot me an email. I check my email all the time. I'll get up, I'll answer as fast as I can. Or you guys feel free to call me if it doesn't really make sense. I'll try to walk you through it as best I can. But try to be prepared for the test on Wednesday. But for the rest of the night, we're going to kind of go over some review questions. And then tomorrow, we're not going to start till about 7:30. I encourage you guys to get together as a group, work on the review questions as a group until I get here. I have an EMS board meeting. So anyway, let's take a 15-minute break. Let's be back at, what time is it right now? Let's be back at 7:45, and we'll just start doing some group study, if you guys want, and start getting ready for our test on Monday. Any questions, Leedy?
Hey, are we doing CPR next week?
Are we doing CPR next week? Do you need your CPR card?
No. I was going to ask you, do you need a copy of mine?
Oh, no. I was going to wait to actually do the CPR class for the lab day. We just kind of breezed over for the test questions, but I'm going to wait to actually do an actual hands-on CPR class till lab day.
Or CPR lab on Monday of next week.
Yeah, I'm not sure when we're. I know that the syllabus puts our lab days in there. I want to try to get through all the PowerPoint slides and then do all our labs together. So maybe we could just load through our labs. So you guys have the information for the lab. Does that make sense?
Yeah. Okay.
Any other questions?
Nope.
Cool. I gotta stand up.
They got fresh women and fresh mom.
Sure. You baking yourself?
No, my wife wants to make.
Oh, does she?
Yeah.
Well, heck. So they're from your.
Yeah. Okay.
they're not like a grocery store thing.
Well, no. I'm buying groceries, go to go.
Yeah.
Online.
Oh, yeah. I didn't know that. That's pretty cool. You weren't kidding when you were talking about fresh lemon and fresh lime.
Yeah.
It's pretty tasty.
That's the Mountain Dew that day. Wanted that for my birthday, since you know.
You wanted that for your birthday?
I give her rain and stuff to dry. Something that's a little difficult
It's your birthday?
today.
Happy birthday, man.
And the correct depth of compression for adult CPR is 2 inches. Is it 2 inches or the 3/4 front to back?
2 inches. Adults want, your adult is going to be, yeah, at least 2 inches. The infant child's gonna be 1/3 the depth of chest. I dig them, those are good.
These hell questions really got it right out.
Do we have any, true games around here?
No, that's one of these. That's what we don't do.
Another motorcycle guys?
No, we actually had a, what is that? Banditos, banditos. We had a bandito in the town that he wanted to kill his mom over up to him. He's sitting back in county jail.
Who's that?
Uh,
Oh, he was going here not too long ago, okay.
he shoved his mom and she fell and hit her head on the dresser and killed her.
Also an accident or anything?
No, you get
No,
charged.
he didn't give no money.
Yeah, you get charged with murder. It was during, they were fighting, it was a domestic type deal, and so you didn't get charged with murder.
Second degree murder?
For all of them.
Not always got it out.
So like tomorrow, before you got here, we could go over this right here, didn't we? Big old long section.
That's what Brendan, Mom, like, before he was, you know. Really. Why?
Yeah. We had a bunch of teenagers here a couple of years ago, we go to game players and fixed lunch. Well, I guess we do have real names around here, but they're all locked up out there for free.
I had MS-13 shine. Cause I had a gang rangers out here, Sarah, a friend of mine, he said it's kind of wild to come home dead night from softball meeting, you and your daughter,
Yeah.
And they're sitting out there right across the street from where they're living at. And they said something to me, you listen here, some of this, Western Oklahoma, every woman around here pretty much got a handgun on, so if you come mess with me, oh, well, I got a 12-gauge shotgun inside the house. I hear something, I'm shooting before I go home.
Now, when the prison was open and got all the California, they had, we did have a few long rangers that had moved out from California. Yeah, they were the middle man for the road and stuff. Yeah. I think most of them go. They're fixing to bring one back.
Learning anything?
Huh?
Learning anything?
Yeah, if you really want to piss somebody off, put one of them,
Yeah, that's new.
That's if you want to, no, that's if you want to kill them. Yeah. If you want to do
run
it.
there, what you doing, Wanda?
No, not.
Got you working nights?
Well, evenings were probably.
The old stuff is that 1 year pay. The new stuff, you use an 80 all the way up. Which, look at the past, would make me think that they're gonna go all the way out.
I'm out here.
Later.
So you ran, go shut that door?
I was walking that.
Yeah, sure.
We had, 85, so the hospital, that we had to go through, but I don't see us ever get to, we've never got one to work. They're saying there is, in here is, I don't know what kind of insurance crap we'd have to go through to have one of them work.
It gets to the city of Clare, we need one. Only when you get one of those, one of the city council members or upper class, somebody in your town passes away, and say, "We can save you with an AED." That's the only way we'll get one. Really, one of them went out of water.
But yeah, that's a city.
Yeah, I'll see it a little bit. You get the city of Sarah.
After
And that's like the grants.
Yeah, and we turn up on here.
Yeah, getting them the grants for those things, they're probably gonna be a match grant. You getting them to match it, so we're having a hard enough time getting them to match the grants.
We get grants, but don't do this class. You know, they're having, what, I know this was a part of it, and what with it. No.
I don't think he ever got his advance.
I remember he saying that Tanner will come to finish taking one of his tests.
That he'd be advanced.
Still need to move up the other year.
Now, Woody's just a wonder if he's advanced. I think he's got his advance.
That's the inquiry. I guess they're running the,
Yeah, they're running the call. They have to. I talked to Kirby this weekend, he was supposed to holler at me here today so I could get keys. He said he sent me a Snapchat last night and talking to a dozen.
He hired somebody to come out there and clean out around his farm.
Oh, really?
he's getting the priority set, getting extra deer feed.
Oh, yeah, he's been on all kinds of.
Yeah, he bought some new feeders, sent me a snap of those. I've always wanted to try one of those. Yeah, let me know how it works, 'cause I'll be wanting to get some of those too.
Self-feeder.
Yeah.
I mean,
It's just one of them feeders that come down like this on the bottom. It doesn't have a spinner or nothing. It just comes down with the feeder like this. Yeah.
No, I told him to run a track house, came up and cleared it out. I don't know if he came up and cleared it out.
I wouldn't, I like those, but I think what you're gonna run into is they're gonna feed more at night. You know,
It's right there, it's not going off.
because we've been rating that with our electric feeder. I'd set them off in the morning, like 8:30. And literally that corn would sit there all day long, and the deer would come out. We see some of them there in the daytime until they start. We start going down there, getting them ready, they'd all be nocturnal. I haven't set up nothing. No, I haven't.
You know that one I had that video of, that's what, like, my pickup? You do it.
Last year, we set up like, with none of them running up in the morning. It was all ice and snow and
Yeah.
50 mile an hour wind. Well, he goes, nobody else is going. I said, I'm going.
My son went.
I went to stand and
The truck stop.
yeah, me too. I went to stand that all him or Eli was going to. I went to stand that morning and shot a good sized run for him. First thing, like something that in the road there really good. I was like, well, that's a good way to do it. And I loaded him up and I sat him back.
I set the paper on 11:00. My first day.
All right.
And then folks in there.
I was burying in there when I was getting
So let's go ahead and do, you guys want to do the reviews or do you just want to do the end of chapter?
In the chapter, because it helps,
You mean the review and practice exams?
Well, there's a stop, review, and remember. It's in each chapter as you're going through it, which if you look at,
every little section.
yeah, there's, like for chapter 1, there's on page 11, which I don't agree with their answer of number 1. I tried
I
to,
think I changed that.
I tried to see where they came up with 4, because that's what they have as the answer.
Oh, we went over that, and we never could find the difference.
No, but in the text, you only have 3, EMT, AMT, and paramedic. And that is, I mean, that is truly your 3 main levels in EMS, right?
Emergency medical technician, advanced EMT, and paramedic.
It doesn't say anything about EMR. You guys are pre-EMS, right?
Also, because it's an EMR book, so they gotta throw us in there.
Well, you know, I don't know, that's why I'm thinking it's 3.
What's community paramedic?
Community paramedic is just a paramedic, and it's not everywhere yet, but a community paramedic is a paramedic that's had more training, and they typically go and do like house visits with people to try to prevent overuse of ERs.
Well, that's like the number 2 question. I mean,
911 call,
yeah, the 911 calls are answered.
closest police.
It's supposed to be at a public,
Safety answering voice.
yeah, but that's in big cities and stuff. Out here in rural Oklahoma is, that's the closest police or fire station.
Well, but not always, because it's still going to be you guys would be considered at a public safety answering point. Because you have a dispatch and you have 911, right? So even though that it's with the police department, which everybody that's out there, just try to think of it like this, it's still a public, it's still a public safety answering point, even though it's your local police department, fire department, our sheriff's department answers. I'm trying to think if there is anybody that is dispatched from a true dispatch center here.
Not in Western Oklahoma. There is in Oklahoma City, but not.
Yeah. But you guys are still considered a public safety answering point. Yeah. And yeah, I understand that that's what the book's gonna wanna, or that they're gonna want. Because You went with the closest police or fire department, like us, the sheriff's department.
So that's New Hampshire jobs over there.
Yeah.
So,
And used to, the hospital did, so. A third service EMS agency is one that, yeah. Then the minimum EMS level required for staffing an ambulance, and that's key there, staffing an ambulance is the, yeah, EMT. Remember that an EMR can't, you can't staff an ambulance with EMR. You have to have an EMT.
that's the lowest level you can have on the ambulance.
Now,
Unless there's an EMT on.
yeah,
And the EMR.
Yeah, there has to be at least-
Right.
there has to be at least one EMT on that truck. Even though services like ours used to use EMR to drive, and some of the other ones will use EMR to drive. Most of your services now are getting to where if we're gonna hire you to do an EMR to drive, we want you to seriously be considering an EMT. Because you really put a strain on your other partner just as being an EMR.
So this almost sounds like we're getting a short term fire department.
Eventually they'd like to, but obviously Sarah ever doing it because we do not have a.
No.
I think Sarah's gonna pay for full-time EMTs currently.
Your FAA, I think, has been fighting that, or your Rural Firefighter Association has been fighting.
It's not.
It's not rural, it's also up there in New York, because a friend of mine, he's on, he retired from, some little town outside of New York, and all his departments, Madison now, the volunteers, once they get off work, they're like us, now they gotta go to school, be EMR, because they're saying that the fire department that responds to a wreck in a rural state or whatever, a rural town, that they're not allowed to work on
Yeah,
until an EMT arrives or an ambulance. And if you're 15 miles out, your ambulance is coming from 30 miles, so you're gonna sit there and you can't do nothing.
what they're gonna do to you guys, if it keeps going this way, is the same thing that did the EMS. We used to be able to have an ambulance driver, so you come and take a class, and you could get an ambulance driver certificate or whatever. And so, like for us rural people that we don't have a whole lot, and it's volunteer services, it's not real hard to get an ambulance driver. It's really hard to get an EMT, and so now they've made them where you can't do the ambulance driver, you have to be at least an EMR. Well, that killed a lot of your people doing it. And so, anyway, matching. Number one has a minimum level of training required to staff an ambulance.
EMT.
Is most likely to get to a scene first. Yeah, EMR. Has the greatest number of hours of training. Paramedic. Performs the most skills with minimal contact with a physician. Has more training hours than an EMT, but less than a paramedic. Get a little closer microphone for Leedy. All right. Move on through our chat. Leedy, we're just going through right now, we're on page 18. We're going to do the chapter review. How about we just kind of go around the room, and you guys could work as a team to answer it if you don't know it, but let's just go around the room and try to read and answer the question. So,
Your turn, Bill.
You're the leader this here, David Jack.
oh,
Which of the following statements is false? EMS system includes hospital, emergency department.
Page 18. We've already done all of it. We don't do this.
So we're not doing a critical thing. Right. Which of the following statements is false? The EMS system includes the hospital, emergency department. EMRs are part of the EMS system. EMRs are trained to respond to emergency first. Emergency medical dispatchers are also EMRs. Hey, I say D.
you gotta pass the computer too.
What? Yeah, because they gotta hear you.
Lady don't need to hear.
It's D.
I say D.
The
Which
least
one is
is
false? Emergency medical dispatchers are also EMRs. No, they're not.
No, they're not.
The EMS system includes the hospital emergency department?
Yes.
Yes. Emergency medical services, yes.
That means that's.
That is your emergency room as well.
Why? What's the rationale behind it?
Because they perform emergency medical care.
Because that's who you're. Let's go and we'll read the rationale.
The rationale?
To help it, because there's obviously, some disagreement on it. I gotta find it. All right, so chapter 1, chapter review.
Yeah, they got that jacked up in the back looking for them darn things.
Hey, this one don't have any rationales.
It don't on that one?
It only goes through page 15, 16, and 24. That I found.
What is it, David? Says back there in the back?
Yeah.
The answer is
Page 18 to 20.
It says page 8.
See, that's why I told you to go first.
Number 1 is D.
But
It says to look at page 8.
That's what we're doing. The EMS system. Since you will be part of the EMS system, it is important to know that all components and how it works, the depth of the system, and various personnel involved may surprise you. Trying to find where it tells us that. Basically, it's
Because it's a trauma center.
I'm just trying to find where it talks about it. They say it's on page 8.
Yeah.
Mainly this page is on. The answer is actually on page 10.
The following are types of specialty hospitals available in some EMS systems. Trauma center has around-the-clock availability of a range of physician specialists.
The EMS system continues into the hospital emergency department and beyond. There it is. Page 10, that's where the,
Go ahead, Spunky Monkey, you read your part now.
that's the computer.
Here,
As an emergency medical responder, you will respond to the scene of various types of emergencies. Your primary goal during your patient interaction should be to obtain an ECG and give appropriate medications, obtain an in-depth history of the patient's medication history, prevent further injury and make life-saving interventions consistent with your training, perform the interventions you think the emergency department would do if the patient were there. It's B.
Wrong.
C, you going with C.
all right, Coulter.
I ain't doing it.
You don't read in
really
front of
can't.
people, I'm telling you. Your turn, Justin.
I'll read. Got him to turn it.
Don't worry, it's not a camera, it's just.
The patient is in need of an intervention to open her airway that will allow her to breathe with ease. At what minimum level would a responder be trained to provide this type of life-saving intervention? A.
That's fast. Good job. I agree.
What was you getting ready to do? Oh,
You already have your answer, don't you?
No, I read the question before that guy.
Preparedness. Okay.
Over here, Dave, you gotta come over here and
You gotta
read it,
come
so
over
we don't
here.
have to move the computer from table to table.
You guys not like these guys?
Grab a chair up there for.
We don't like these guys.
Hey Joseph, you gonna sit over here? Culper don't bite hard.
Okay, number 4, you are at the scene of a motor vehicle collision at 2 a.m. The patient requires rapid transportation to a hospital that can operate immediately on his traumatic injuries. Which hospital is suited to receive the patient? I put C, trauma center.
You read again.
Okay.
Now, we got 2 big babies in this place.
All right, number 5, it says laws that are written to, what did I do?
No, laws that are written and adapted.
Laws that are written and adapted governing scope of practice and or authorizations are created by, I put B on that one, state legislator.
B.
B. Okay. You gonna read one of these questions, Philip?
Go ahead, Justin.
Go ahead, Justin. You get the next one.
You're working as an EMR at a private industrial recycling facility. The company has created a guidebook telling you and the company's other EMRs what you're allowed to do. This is an example of.
I put D on that one, national training circular.
Agency rules.
Agency rules and regulations.
Yeah.
Be A.
BA. I got that one wrong. So far, I got one wrong. All right, Bill.
Quality improvement plan continually evaluates all the following areas except patient satisfaction, EMS provider documentation, completion of duty requirements, patient assessment.
I put C on that one.
All but A. Except areas of A. Patient satisfaction.
So I got 2 wrong.
As long as we got them alive in the ambulance.
Okay.
I wanna have,
Lee, do some?
Do you need speakers?
I got 2 wrong so far.
No,
I didn't think
I
we
feel
could
like
have
I'm getting on, I'm just gonna switch accounts here.
Go ahead and do 8. I'll wait.
Joseph, we don't bite hard, man.
He's like, I ain't coming over there because then I gotta read, huh?
Yeah. Go ahead, Coach.
Just,
It's not on you.
He's gonna let them do A, so we'll let them do A.
just pretend Zane was here and you're reading to Zane.
You know how you read that?
Yeah.
What?
Sorry, just, I gotta,
I've seen those pictures.
All right, Leedy, can you guys do a couple of other questions?
What number y'all?
Which one you want me to do?
8.
8?
What they got on 7?
What did you get on 7?
8.
No.
7 is C.
Oh, okay. It's the committee. God, dags that thing's kind of sensitive. I know.
All right, I wasn't paying attention, so, I just told you guys to answer some of them. Which ones were they wrong? Just number 7? Equality improvement.
Are you still there? Because we can't hear you.
Can you hear us now?
Yes.
You guys got C for 7, right?
Yes.
I was right. Let's see.
What other ones did you think they'd missed?
I was right.
2 was C, right?
Yeah, number 7 is C.
And 2.
2.
I just missed,
7 is C and 2 is C.
so I just missed one so far.
Okay. So number 8, leading number 8.
Okay, the Quality Improvement Committee makes the determination of proper or improper care primarily by D.
Option D is reviewing the patient care run reports for an individual call. All right, everybody agree with that or understand why it's that? I was trying to get on my phone so I didn't have to yell across the room, and that didn't really work at all that well. We got a lot of feedback, so sorry about that. All right, if you guys could do number 9 as well.
It is not acceptable to use a pocket reference guide to help prevent errors in a patient's assessment and care.
False.
B. False.
And anybody need or want the rationale behind that? Okay. I think their pages are off anyway. There's a bulleted point. Double check important facts or decisions. Use pocket reference guides, protocol books, or cheat sheets. I don't know very many EMS people that don't use that kind of stuff. All right, we'll do the last one here. Whoever's next.
David. What level of provider will typically administer intravenous medications to a medical patient with little or no physician's contact? I put paramedic.
Paramedic?
Hey,
I agree. All right, you guys want to do the matching or do you go on and just do questions like this?
Get it, big boy?
I
I will
did
go on.
And make sure you do the matching. Always understand that.
I just got my books. I don't have any answers for this.
So page 34.
You ready?
You guys want to do the multiple choice on page 34?
Yeah.
Okay, it says well-being is best defined as, I put D, prevention disease through the proper use of equipment. I could be wrong. I could be wrong.
Read all of them.
Okay, you got prevention from violence and hazardous materials, staying psychological stress-free, general concept of safety and health in the EMS, preventing disease through the proper use of equipment.
What do you guys think?
I think it's D.
See?
I like C, and in the back of the book I like C.
Okay.
Because well-being, think about it, it's a general concept of safety and health in the EMS.
That's like, if anybody's on, Aflac, they give you a wellness check if you go to the doctor and have your checkup every year.
Yeah, kind of like
The other
T
ones are
does.
very specific.
Right.
So think of it like that. I mean, well-being is more of a general thing. Now, if you want to stay stress-free,
This is the wrong job for you.
yeah. So that's part of well-being. But
Well, preventing disease through proper use of equipment, that sounds more like a lab.
yeah, well,
Yeah.
preventing disease through the proper use of equipment would be your PPE.
PPE.
So
Right.
you're using personal protective equipment to protect yourself.
All right, Bill, get number 2.
The best method of protecting yourself from danger is to know defensive tactics, practice concealment, know exactly how far you can go before encountering danger, be observant, and avoid danger altogether.
I put D. I put D.
You didn't let me finish.
D is a dog.
Mhm.
Be observant and avoid danger altogether. Guys, that's the best practice you could do. So, now, the others are kind of more if you find yourself in these situations. But, all right.
The difference between cover and concealment is that I'd put B on that one, but I think I got
Concealment
it.
hides your body, cover protects it.
Mhm.
We had a whole block of that in Cleves.
Yeah, so you guys, you kind of, what I'm seeing is make sure you read these chapters and understand the definitions and stuff. So. All right, number 4.
Which of the following
You gonna
is,
read them all?
I guess, nobody
Well-
else is jumping in here.
Matt's not. These chickens.
There's 4 and 5. We'll let Lee do 4 and 5. And not the same person, Lee.
I think Liddy went home.
They're like, we're not doing this anymore.
Which Which of the following is not an acceptable method of determining a hazard during the size of a vehicle crash on the highway? The answer is A, approaching the vehicle to examine the shipping papers for hazardous materials.
Yeah, you can put that. All right. Good job.
Thanks.
Standard precautions.
Go ahead. Hit it.
Okay. Standard precautions are best defined as taking all possible precautions against disease, whether or not there are risk of transmission. A practice to prevent exposure to disease. Wear gloves on any call. Wear gloves and eyewear on all calls, or any calls.
A.
You guys are going to A?
Yeah.
What should be D?
It's B.
I was right, y'all was wrong.
Practice to prevent exposure to disease.
I was right on that one.
A covered them all.
That's that trick crap that they do too.
All right, let's, we'll do, since a lot of you guys just got your books today, and I know that some people at Lee just got their books today.
48?
Let's do the chapter review. We're on chapter 2, right?
Yeah.
Yeah.
48?
Page 48. Let's do the chapter review on chapter 2, and then I'm gonna give you guys, let you guys go. I kind of recommend that you guys that just got your book, try to hit some chapter tonight before you go to bed. I know it sucks, but we got to get caught up with with you guys reading it and understanding it. So.
I'm up till midnight anyways.
All right.
I am too if I had a book.
So, which of the following is usually not a sign of stress in the EMR?
I put C, making decisions rapidly.
Yeah, so the other ones are signs of stress, right?
Mhm.
Yeah.
So irritability is a sign of stress. Loss of appetite is a sign of stress. Difficulty sleeping is a sign of stress. But making decisions rapidly, you have to, that's just something you need to do at your job, and you have to be clear of mind to be able to do that, all right? So good job. Which of the following is not recommended as a method of dealing with stress in EMS?
D.
D, going out drinking with colleagues. Even though that's probably how a lot of
people deal with stress.
yeah, a lot of EMTs. I know when I worked in Wichita, the EMTs that got off at night met the cops that got off, or the night duty EMTs met the night duty cops at a bar that opened specifically for EMS and cops.
That was owned by a firefighter.
Probably, yeah. And they all went down there and they had a couple drinks before they went. Not saying it's the right thing to do. I just know that a lot of us do it that way. Western Oklahoma, you're dealing with volunteer services. You don't have that as much. So whenever you do see somebody that is drinking a little heavier than usual, it's like gosh, she's drinking 2 bottles of 9, not just 1 or whatever. Take note of that, especially if it's one of your friends or colleagues, and talk to them. Hey, everything all right? So, all right. A pathogen is a C, a disease-causing organism. Pages is 48. I just want to make sure we're right on all of them. No, that was number 3. C. Good job. So, a scientific test for a disease? Yeah, no, not that. Method of protection against and sign or symptom of disease. No. All right. One method to prevent disease that can be taken before the call is
B, getting vaccination.
yeah, getting your vaccinations, right? Because wearing gloves whenever you're in the station or rescue vehicle is silly. And actually, getting a tuberculosis test, is a TB test, is just something we do. It's not going to prevent. It's going to tell you whether you've been exposed. Assuming all patients in bad sections of town are likely to carry infectious disease.
Hey, now that's possible.
Well, that'll get you in trouble quick, because you know what? There's a lot of people in nice parts of town that carry the disease too. So, all right.
That's what Matt does his profile.
So we decided getting vaccinations was the right answer for number 4. All right. So it's B as in boy. All right. The appropriate personal protective device you should wear when you suspect the patient has tuberculosis is
A.
Oh, we got a couple different answers here.
thinking D.
Thinking D.
I think it's B.
Correct answer is A.
There you go, Matt. Fist bump.
The HEPA or N95 mask is the only one that'll actually filter out. So, in all reality, I think a surgical mask is probably to protect you in the back of an ambulance. With TB, it's exposure to the droplets, and my understanding of it is it's a long exposure. So with your Native American populations, you still see a lot of TB because how they live. I'm not saying anything wrong with it, but they have people come stay with them. They don't get out of, sometimes they don't get out of the house a lot. They're in a shut up house. Somebody comes over to stay with them, a TB cough in a shut up house with the droplets, and it makes everybody in the house susceptible. We got exposed to TB, but we were told that our risk was very low because we're in a ventilated ambulance. They said not to worry about it, and we got tested and we're fine. But so a gown would most likely be worn in which of the following calls?
I put D.
I put D.
Okay, so we all put D. A woman about to give birth. Be a good call to wear a gown on, right?
Yeah.
So a patient who requires suction. You don't necessarily need a gown, but what do you need on that one? Yeah, you definitely need eye protection and respiratory protection, or like they're saying, face mask. A child who fell and was has a wound on her leg with steady flowing blood. Yeah, probably gloves and eye protection. Good job. And a conscious man experiencing a heart attack. Gloves. Yeah. So the woman getting ready to give birth is probably the most logical answer because they're dealing a lot of fluid, right? Which of the following is not a sign of obvious death or resuscitation should not? Which of the following is not a sign of obvious death where resuscitation should not be initiated?
I put A.
Yeah, because decapitation, that's an obvious sign, or obvious sign of death.
He's
Right?
still alive, he's still kicking.
I'm telling you.
Tissue decay and rigor mortis. Those are all three signs. Their injuries not compatible with life, or situations not compatible with life.
Unless the Walking Dead is around.
Exactly. If it's a zombie apocalypse, then you should shoot them in the head. All right. So A, the stages of death and dying include all the following except, and these are all the signs of mourning or grieving or whatever.
I put D too.
D.
Yeah, because depression is, acceptance is, and denial is, right? As I'm telling you, for your test, you'll want to know what, I think it's all five stages are, okay? Whether you got to come up with a mnemonic to remember it or however you need to do it, you will be asked questions on the 5 stages. Body mechanics refer to,
I put D, lifting with your legs, not your back.
See.
See?
okay, body mechanics refer to, they're saying it's A, how your body is used to live.
Okay.
Using mechanical devices to lift patient bodies, no. Knowledge of the working of muscles and bones in the body. No, we're more using body mechanics. In this, I would say that this definition necessarily isn't right either, because body mechanics could be on how you walk, but it's how the movement or the mechanics of the body are. So I don't think knowledge of the working of muscles and bones in the body is necessarily correct. And lifting with your legs, not your back, is just a proper way to lift, not body mechanics. So let me make sure 9 is A, yes. That's what they're saying. I could definitely see why you guys like to see though. 10, and I guess maybe what we could do on that one, 9 and page 38. We'll see if they have the right page on there. I just want to, sometimes the answers are wrong. Body mechanics is a term described the proper use of your body to lifting. Lifting is a mechanical process, and your body is a device that does the work. Something as simple as a posture had a profound effect on your body and how it works. The following concepts comprise body mechanics. keeping your back straight, grip, ensure good and solid footing, don't twist, communicate. So there's your answer. That's why it is what it is. So which of the following procedures should you follow while lifting?
I put C, consider the weight you are lifting before you lift it.
Consider the weight you are lifting before you lift. That'd be a good one.
Because if I'm trying to lift coach, I'm going to consider his weight, not the personal coach. Yeah.
So the first one, they say, keep weight as far from your body as possible. We can eliminate that, right?
Need to be as close to it.
Lift with a strong muscle of your back.
No,
You make eliminate that, you shouldn't be lifting your back, all right? Consider the weight you're lifting, that's a good one. And then spread your legs as far apart as they will comfortably go to lower your center of gravity. So we can, basically in that one, we can eliminate every other answer, and then we're stuck with consider the weight you are lifting before you lift. And that, I like that answer anyway, so good job. I'm gonna leave it up to you guys, it's 8:20. We can do another chapter, we'll all go through, read, and go over the rationale, if you guys wanna do that. Or you guys go home and read, it's up to you, since you guys just got your books. What do you guys wanna do, lady? You wanna go do one more chapter this way? I'm sorry, I didn't get that. You guys are speaking in tongues. We still didn't hear you. I think they said. Did you guys say you're calling it a night?
Yeah.
Okay. There it is. Thank you. I heard at that time.
Well, they probably went through the whole book or halfway through it anyway, so. Let's do another chapter.
You guys want to do? Okay, we're gonna do another chapter here at Sarah. You guys can hang out if you want, and go over. I'll be reading them, and I'll be giving you rationales and discussing it that way. All right. So chapter 3. This is the medical, legal, and ethical issues. Let me make sure I got the right thing. You got
58.
67.
Yep, 67.
Okay. All right. Rules, regulations, and laws, though they may vary from state to state or region to region, that govern the practice of emergency responders are considered to be
A scope of
Scope of practice.
Yeah.
Oh, rules, regulation.
I agree with the ones that pick scope of practice. Good job, because we're talking about the rules, regulations, and laws. Protocols are just guidelines written by your medical director or approved by your medical director. Obviously, it's not negligence or proximate causation, right? So, communication obtained from a physician while on a call that provides assistance with your assessment or care of the patient is said to be B, online medical direction. I agree with that, right? So protocols that are written, so they're considered what? Offline, right?
Offline, yeah.
Offline medical control, as we're talking about protocols. And the scope of practice we know is the rules, regulations, and laws. It's not necessarily the communication obtained from a physician, right? So, all right, good job. Written guidelines created by a medical director to provide an EMR with a plan of care for specific medical situations are called
D protocols.
Protocols. That's good job. I won't even explain. You guys seem to grasp something pretty good. Permission for treatment obtained directly from a patient who is in need of care is
A. Express consent. Or express consent, yeah. Never mind, that's the kids.
Yeah, written consent. It's definitely not that one. It'd be B, express consent. Implied consent is two different. Yeah, unresponsive. Any normal person.
What any normal person would want you to do.
The other side of compliant consent is when you're dealing with minors, right?
Yeah.
The parent, any normal parent want me
I
to.
had to take my son to the ER. He's 18. They made him sign permission to treat and made me sign for responsible party.
Oh, because they wanted to make sure.
Yeah, they wouldn't let me sign for permission to treat him
Because
he's 18 years old. And then today when I called over and said I need to get a copy of his x-rays, but we can't release him to you, only him.
They should have had you sign.
I'm like, so you're telling me that I'm responsible for him, but you can't release me his x-rays?
They should have had you sign a permission, had him sign a
A
HIPAA thing saying that he could give information to you.
Yeah, he's gonna sign one tomorrow while he's over there at 6:30 in the morning getting his x-rays.
Yeah.
Because he has to go to the orthopedic surgeon the next morning.
Nice. And they're just doing what they're supposed to do.
Yeah.
So, permission for treatment obtained directly from a patient who is in need of care is.
The express consent.
Oh, yeah.
We already did that, sorry. Sorry, guys. Patients who are able to legally consent for their treatment are also able to decline treatment. This is more commonly referred to as
I put A, refusal of care.
refusal of care. Good job. So, healthcare proxy is somebody else making that decision, right?
Yeah.
Express consent, well, that's just we get permission directly from them, and then advanced directives are written.
Yeah.
Healthcare providers often come in contact with their patients' personal information. This information is commonly referred to as.
I say D, protected health information.
Okay. Any other?
A.
Okay, healthcare proxy is that person, remember?
See, the healthcare providers often come in contact.
It's either D. I think it's
It is
D.
D. I just wanted to see if we elicit some discussion on the answer. So, a healthcare proxy is that person, or is a person that has a right to make a decision for somebody else. A do not resuscitate order is just a written piece of paper if that person becomes goes into cardiac arrest for you to do not do CPR. Ethics, that's obviously not it. So protected health information would be the correct one. An on-duty provider of medical assistance is said to have a blank when there's an emergency call for assistance.
B, duty to act.
Yeah, B, duty to act, right? So the rest of them are more negligence and other that side of it. So when it's responding to the scene of a crime, in addition to caring for the patient, the emergency responder should also be aware to
I'd say A.
preserve evidence.
No changes made to the scene.
So when responding to the scene of a crime, in addition to caring for the patient, the emergency must also be aware to. Well, it's not D. Act recklessly when it is in the patient's interest.
Solve the crime.
Let me know, I know it's not B, even though we have a lot of them to try that, it don't work.
Solve the mystery of the crime. No, you're not supposed to do that.
Yeah, because you
Put
brought
themselves
this
in harm's
one up.
way to protect bystanders. No.
No.
So,
Because you brought this one up because it didn't, I don't think we'd even got to it yet in the book. And you brought it up about do what you need to do, but preserve as much as you can while you're working on the patient.
So in many states, there are laws that require emergency responders to be mandated reporters for all the following except.
D.
I'd say D.
No, I agree. So suspected acts of domestic violence, yeah, definitely. Suspected elder abuse and suspected child abuse. Just an update, I have not heard from the state. They have not answered my question. So yeah. When an emergency responder begins the care of a patient and does not complete the care provided, he has put himself at risk for charges for read all of them.
C. I think it's C.
I think it's C.
Yeah,
Abandonment.
you're
Abandonment.
abandoning that person, abandoning.
Yeah, because I'm taking care of you.
Negligence, remember, negligence has the four things that have to be proven. It has to be, you have to have a duty to act, because you didn't follow that duty. Is it 3 or 4? That was 4.
I have to go back and look. Negligence is defined as failing to follow a standard of care which causes or worsens the patient's injuries or conditions. Let's see, and it's going to be the duty to act, breach of duty, and proximate causation. So 3.
3, okay. Whenever I was going through, like, wait a minute, I can't think of the 4th one. Well, there's a reason. All right.
No. There are 4 components required
Okay,
for
so-
negligence. Duty to act, breach of that duty, Harm to the patient and proximate cause.
Yeah, and the harm thing,
Yeah.
it could be physical or mental.
Yeah.
All right.
Right there in big red letters.
You guys want to go over another one? Chapter 4.
We're here, might as well.
Yep.
Page 79.
I'm gonna pull the chair in.
Do y'all like standing?
Oh, I'm fine. I just, is it what computer it is to use the people actually.
Is anybody that stayed?
Yeah, if there's anybody that stayed, and sometimes I have some people that watch the thing. So, all right. So multiple choice, page 79 for chapter 4. Make sure I have the right. So the medical. Okay, so this one's going to be over medical terminology. So the medical prefix that means above normal is C. You guys are going with C. So it's a let's see here. Page 79C. So hyper above. So above your normal blood pressure. Hypertension. Good job. In anatomical position, the patient is
Standing and facing forward, the legs, shoulders width apart.
oh, sure.
Turn forward, no, turn to outwards. On to turn forward, yep, A. D. What do you think, Phil? Or no, D. I think
Patient
it's
standing and
C,
facing forward, legs shoulder width apart, arms at the sides and palms turned forward.
because that's the way Atlas says, ain't it? The man, whatever's, not Atlas, whatever the
So
guy's
D.
name.
C. Right, or just send it across.
Just a sec. I'm going to answer and they let me know.
What is that DNC?
All right.
It's on 72.
Standard usage.
Right there.
We're talking about the anatomical
Standing and
position.
facing forward, legs, shoulder
Yeah,
width
it's C.
apart, arms by the sides. Yeah.
Yeah,
So C.
Do they talk about palms facing?
Palms facing
Yeah.
forward.
All right. So we're going with C.
No, shit. I read right over that one.
With the arms crossed?
Yes, I read right over it.
Oh,
Well, I
yeah.
seen the standing facing and
You
then.
had them all, but yeah, okay. All right. The heart, lungs, great vessels, and esophagus are contained in the thorax. I'll let you guys talk it out.
C.
Okay.
Thoracic cavity.
Yeah,
Thoracic
thoracic cavity.
Good job. Yeah, it's the thoracic cavity. The cranial cavity, what's there? Brain. Pelvic cavity, we're more dealing with
Intestine.
intestines, reproductive organs, right?
Right.
That's what protects your reproductive organs. Your thoracic cavity, heart, lungs, great vessels, esophagus are all contained there. And then abdominal cavity, what are we looking at?
Stomach. The.
Stomach,
Diaphragm.
liver, pancreas. The diaphragm separates your abdomen from your thoracic cavity. Okay.
That's
That's
the
your-
one that's in, the right.
Diaphragm?
Not diaphragm, the, what was I thinking of? I don't know what the picture's at.
So your patient has a minor cut on his right forearm. In describing the location injury, you would say it is,
Distal to the elbow.
okay, so right forearm, distal to the elbow. Yes, it is. It's not distal to the wrist.
That should be your fingers.
You're right. So I will agree with you, distal to the elbow for a good job. In prone position, the patient is
Prone's lying on your stomach.
Lying on the stomach.
Prone, you're laying.
Yeah.
flat
yeah. And
face
so what do you want
down.
to? So you're calling that B, lying on the stomach. Good job, guys. When compared to the bladder, the heart is
Superior.
Yeah, I agree. Good job. You're treating a 6-year-old who fell off her bicycle and scraped the front of her knee. This injury would be considered
Superficial.
superficial.
Boo-boo.
I just want to make sure that it's
I don't think it'll be anterior or posterior.
the stomach, intestines, liver, gallbladder, pancreas, spleen, appendix, and kidneys are contained in the
Abdominal cavity.
abdominal cavity. I agree with that. So 8 is D. Remember, pelvic cavity is mainly your reproductive organs. You have a little bit of intestines, but the patient found in the left lateral recumbent position is.
Flat on the left side.
I'm gonna say C.
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 C?
C.
C. All right. Good job, guys. The bladder, rectum, and internal female reproductive organs
B.
are B.
Yeah. B.
All right. You guys actually did. I'm fairly impressed that you guys did as well as you did on that, because I know that most of you
We
don't
was
have the
writing
answer.
it down.
And you guys weren't flipping to the back, and you guys did very well on it. So good job. Because to me, this chapter for you guys, it should be more foreign. So you guys did pretty well on it. So you guys want to do another one?
You keep giving us that option, we're gonna be here all night.
Well, we only have.
Well, it helps when I'm with people to study. Because what I got the TV on and I'm looking at it, and I'll begin to interested in something on TV.
Yeah, I get to play Minecraft.
Do you play Minecraft?
Oh, yeah. I like big old castles.
My kids play Minecraft.
Minecraft, what the hell's that?
Build
It's a
stuff.
block game. You
Build.
just build stuff out of blocks. You fight zombies and
Creepers.
99?
creepers.
99?
I hate the new creepers.
108.
108.
Oh, okay, that's stopping review.
Yeah, you guys do the stop and reviews. I mean, the more stuff you guys do, the more, and that you go look up and read.
I don't know if you watch Facebook, but they got a skeletal guy. It's over in Europe. Well, anyway, the bones are sitting there. Well, he's got his old pecker. It's all bone. And women or people walk by and all of a sudden that thing will stick straight up like that. These women freaked the hell out. They could have got away with this in the United States.
Not anymore.
Yeah,
Uh,
that's politically incorrect.
but no, the more that you guys read over these, read the rationales behind it and stuff, the better off you're going to be. Okay. So we'll go ahead and do 5. So let me make sure I got the right. So I can just flip to it. 108.
Bless you. Just don't go there
All right.
and blow your head off.
The study of structure is called
Anatomy.
anatomy. Yeah. Homeostasis. Do you guys know what homeostasis is?
Yeah, but I can't remember.
Kind of the equilibrium that the body strives to be in. The body strives to be in homeostasis. Physiology is, you guys know what that is?
Physiology is the study of the body.
The function. The function,
the
right?
muscles and
I don't even know what that last word is, so look it up. All the following are components of the pelvic girdle except the
ilium? No.
Now read them. Read all of them.
Clavicle. Oh, clavicle.
Yeah. Where's the clavicle at?
Clavicle's up here.
All right. So guys, whenever you get a question, don't let it freak you out. Kind of like what you do. You're like, I don't know the pelvic
I
girdle,
look ilium and I'm trying to think of what the hell the ilium is.
because you hadn't studied it. And you just kind of hit the
Right.
first one that came out. Read all of them, because sometimes something like that, you're like, clavicle. Well, that's up here. That stands out, and it's just obvious. That'll be the same way on your EMR test. Okay. If you see one that just freaks you out first, take a deep breath, read it, think about it, and then read it again. Okay. Don't just freak out and guess. Okay. Because chances are that if you read through those answers, you eliminate a couple of them just like that. You're like, oh no, there's clavicle. That's definitely not it. It'll help you out. How many muscles are there in the body? I got to look this up. I think I know what it is. Kind of a crazy
What do
question.
you think, Philip?
That's what I thought it was. I was correct and you're not.
Huh?
I said I was correct and you're not. You got about half of them.
So there's 6 of them.
I think D.
It is D. You're not expected, and after you guys read this chapter, this will be one that you probably need to read, and probably read maybe a couple times, because I don't think they're going to ask very specific things, but they might ask questions like that. How many muscles or how many
600.
bones? So you're looking at, I believe it's 206 bones in the human body. And so they might ask you things like that, or they might ask you, what's another name? What is the bone of your thigh called? That's your femur.
And then tibula's the one.
Yeah, tibia is the one that makes the
That's
T.
that little,
Yeah.
it's a small one on the side of your.
No, that's the fibula. The tibia makes the T, it's basically comes up here and then goes down into the T. Your fibia is
I used to know some of this stuff. It's been a while.
all right. So in what order does air enter the respiratory system? You're going with A. Alveoli is definitely the last, right? Bronchi is definitely the next. So then we have a trachea and a larynx. I know it's trachea before larynx. So now we got to know our difference between larynx and pharynx.
Larynx is right.
Pharynx, then larynx, then trachea, then bronchi.
And so you're sticking with A?
Yep.
You're right. Good job. So as you see here, this is quite possibly could be a type of question that you'd see on National Issue. And notice it's not necessarily what each one of them are, it's just the order. Okay? Which of the following blood vessels contain valves?
I'm gonna go with A.
Okay, arteries are high pressure. They don't need valves. I'll tell you what a valve does. As the heart pumps and it exerts pressure, you got to understand that your arterial side is always under high pressure. But as it comes through the capillaries and comes back to the venules and veins, now you have a lower pressure side. So that valve, after the heart stops, it'll slam shut in that vein or venule.
Veins.
Vein and venules.
And venules.
It slams shut to keep that blood from backflowing. Okay, so it holds it there. So
Like pressure valve.
it could continue to go up the system.
So they be
Yeah, B as in boy.
Veins and venulas.
The exchange of gases, nutrients, and waste product occur in the
Bronchus?
Nope.
Capillaries.
okay.
D.
6, you're going with D.
Mhm. Then blood vessels where exchange of gases.
Yep.
nutrients, waste. Capillaries.
Now, there are in your lungs, you have your alveoli. What are those? That's also where gas exchanges. I'll just answer it so you don't look up. Your alveoli are just big, huge balls of capillary beds. Okay, so that's at that level on both sides. You got to understand at the lung side, you're offloading waste and onloading O2. So you're offloading CO2, onloading O2. Go down to the body side, or what we just know as our capillaries. You're offloading oxygen to the body, and that blood cell is taking on CO2 to carry back to the lungs. Okay. Functionally, the nervous system is divided into the. I'll have to look this one up. Actually, look them all up.
The central nervous system. They don't say that though. Somatic and automatic nervous system. Somatic nervous system and autonomic nervous system.
So C?
I think it's C.
Yeah, that's the correct answer. The layers of the skin that contain the blood vessels, hair follicles, sweat glands, oil glands, and sensory nerves is the
C. Epidermis.
little deeper,
Subdermis.
little in between.
I say B.
B, dermis.
Dermis.
That's what they're saying anyway, page 108, 109. Is B. Now, number 9. The innermost layer of the skin is the
Subdermis. Subcutaneous layer.
subcutaneous.
Yeah.
That would be correct. I would have, by just seeing what they're testing here, I would have an idea of your layers. So you have your epidermis, dermis, subcutaneous layer, which is above the skin. I don't even think there's a subdermis. I don't think that's a true, right? You look at your books, is there a subdermis?
No.
And then your sub-Q. So know the layers of your skin. Whenever they do a TB skin test, they're putting it in a sub, and just underneath the skin there to try to get the sub-Q tissue. So the urinary system is responsible for all of the following except
B.
human perpetuation. What would be human perpetuation?
You've been holding it for a long time. It scoots you back.
I think human perpetuation is perpetuating or carrying on your lineage. So filtration of the blood, removing excess water and substances.
Regulation of blood pressure.
It helps regulation of blood pressure. Good job. It doesn't help you carry on your. Let's take a little bit of a break. We'll go through all these, if you guys want to, except for like the matching.
No hurry. I don't have to be at work till 8:30.
You guys,
Shoot up this hours.
you guys will want to do
The
these-
matching?
Yeah, the
I
matching.
figured that'd be good whenever
in the late
you're doing your stuff and we're really.
and the labeling. There's a cool little skeleton. If you guys want me to, for the basic bones, I could probably come up with a thing for you guys just to practice. Give you a couple copies of it. You could take it home and just label it. Just label it, just to try to memorize it. So, because it should be just real basic bones. It shouldn't. Heck, say if they had a lower one, you'd be able to. What I could do is I could just make a copy of. I think they have a skeleton here. Does it say that skeleton to take a copy of it, or there's another one not really? Anybody watch Napoleon Dynamite?
Been a while.
Broke my coccyx.
They said they made that movie for like some stupid amount, like 20,000 or something like that. I mean, a lot of money. Oh, yeah. Well, that's usually your best movies right there.
So let's take a 10-minute break, just so I can go to the restroom, and then we'll come back. Like I said, you guys need to do the labeling. I'll try to make you guys maybe a labeling thing off this guy. I'll just print that off and leave the lines.
Lumbar.
And then we'll come back and we'll hit 6.
That's what screws up the old people.
6 chapter review.
COCCCYX. That's a hell of a COCC. YX. How the hell do you pronounce that? All we are doing. There it is. I hate how they do this. When you try to find it. A is clavicle. Right? Major nerves. I don't need the major nerves. Need the bones. The bones. Give me the bones. Some of this stuff, you think you know it, and then all of a sudden you hear the answer, and it's like, what the fuck? Ooh, go pee. All we are doing. Oh. I'm ready for a shower.
Chapter 16.
Well, I feel sorry for my daughter. They stopped growing at the age 16. Well, you were 5 foot tall yet. Must have put her on one of the stretch bands.
A couple of times we used.
Oh.
It was that hard of work.
Huh?
Was it that hard of a work?
Man, my people gonna drive me to drinking again. I'm telling you, I'm thinking about taking a bottle of Jack Daniels back in my office. Be like, I'm going to my office for about an hour. I'll see y'all later. I'm gonna go hide somewhere.
All right, so we're all back.
What are the vital signs of a person's lifetime?
127. All right.
Thanks, Philip. Thanks,
So
Philip.
what happens to vital signs over a patient's lifetime?
Heart rate decreases, respiratory rate decreases, and blood pressure decreases.
You want B? I can get behind B, and so can the book. Kind of told you guys to kind of know those ranges and ranges. Doing good?
Mhm.
Okay. Know those ranges and stuff like that, and know kind of what the heart does. You guys did awesome on that. The interior fontanelle closes between
C, 9 to 18 months.
9 to 18 months. Everybody agree with that?
Where'd you find that at? Did you look it up?
Yeah, back here somewhere.
He's right. 9 to 18 months.
Yeah, I know, I'm not questioning.
Yeah, no,
I was just
you
asking.
want to know where it was.
Yeah, where it was.
When does magical thinking begin? I'm terrible at this chapter, these chapters, by the way.
Magical thinking. That is 3 to 5, ain't it? Yep. 24 to 36 months.
Yeah.
So C, 23 to 36 months? All right. What development stage does the individual form peer groups?
Preschool.
C,
I
school age child.
School age child, yeah. Then 5, girls are usually finished growing by the age of blank, and boys by the age of blank.
C.
See? All right, I agree, 16 and 18. The normal systolic blood pressure in adolescent is
A.
you want an A, at 80 to 120?
Mm-hmm.
Yeah, that's what the book says. The highest levels of job stress occur during
B, early adulthood.
7B, early adulthood. They're still trying to jockey their way up, all right? Good job. All the following usually occur during middle adulthood except
Childbirth.
childbirth, I agree.
Usually.
8 is A. A person in late adulthood has
I'm gonna say A, less tolerance.
Finish reading that less tolerance of tachycardia and decreased metabolism.
C.
It's not.
No,
No, I know it's not C because I don't have more tolerance.
Where you
more
up
tolerance of tachycardia.
Oh,
A was.
It was the right.
Was it? Hey, I was right.
That's just because all you read was the first two words, less tolerant.
Let's tolerate.
All right. At what 3 stages do the most dramatic physiological and psychological changes occur? B as in boy.
Yeah.
Wow. It could be C too.
Mhm.
Thinking about it. Early
Well, yeah, but
adulthood,
in
they know
adolescence-
everything and they've done everything and they've seen everything.
Adolescents, they got the growth spurt and all
Yeah.
that.
D is correct with B. All right, guys. I'll just tell you that's one of my weak sections. It's not something. Obviously,
Yeah, but
I
you're
don't.
still learning though because your kids are young.
It's not obviously like this last chapter that we had, the chapter we had tonight. I was able to talk about most everything on it. This one's just one that you're going to have to know the numbers to get through. Okay. I'm not going to do the section 1 review tonight.
Okay.
All right.
Yeah, we got a lot accomplished.
So, because that's all. I guess we'll do the section review maybe tomorrow,
Okay.
and then maybe
Oh, no, tomorrow you're gonna be late, right?
so
So we
we
went
go
back
ahead
and
and
did worked on all the matching and all that kind of stuff tomorrow.
Yeah. Whatever you guys want to do until I get here. And really, to be honest with you, if you guys want to continue what you're doing when I get here, we can do that too. And I could talk.
Well, if you're gonna be here at 7:30, that's gonna give us an hour and a half. Yeah, to where we can get a lot caught up to where we can go on as we do the chapters. Are we ahead? Are we behind?
Oh, we're ahead.
So we can do that tomorrow. That'd get us up to
I'm going to
here.
go ahead and end
You mean
the
matching?
Yeah, we go
recording, and we're
all
just
the
going
matches
to talk about a few things here.
Section
But
one.
they just had some
Yeah.
questions. So if you guys have any questions, go ahead and email them or.
Like your test you're gonna
text
give
me.
us Monday, is that like a big test, like a